Good afternoon, everyone. Welcome to GITAP, and this is not a real this is a real backdrop. It's not one of the fake ones. I am beaming from Kota Kinabalu in Sabah, and I welcome all of you to the new series on GITAP, where the focus is on the mentors and the mentees. So basically, this is going to be about a 2.5 hour to 3 hour succession of presentations where the trainees or fellows will have an opportunity to discuss a topic or an interesting case, followed by the mentors giving their view on what has been discussed. This is going to be an informal discussion because it should be an interactive one where we all learn from the mentees as well. So this is a start of a succession of meetings where we will get trainees from around the region. We have trainees from Australia, Korea, India, Thailand, and I think that's it, and Japan maybe. But we will start the first presentation with Dr. Nontali, who is the president of TAID, very close friend, and part of the GITAP committee. Nontali, please go ahead and introduce your training.
Hi, Ryan. Thank you so much. And I want to say hi to everyone, and thanks for having us here. So I'm going to start off by introducing our first presenter, my former fellow, who is currently our junior faculty, Dr. Manas Rujivarodom. He is an advanced therapeutic endoscopist. He's been joining our center, which is a division of GI, Department of Internal Medicine, Siri Raj Hospital, Bangkok, Thailand, for the last couple of years. And his main area of expertise is therapeutic, ERCP, and US. So today he will be presenting a case of biliary stricture. Without further ado, Manas, could you please present your case?
Oh, thank you for your kind introduction. Hi, everyone. Good afternoon. I will share my slide. Okay, so first of all, I would like to thank you for an opportunity to participate in this meeting. I will present the case demonstrating challenges in diagnosis of biliary strictures. So he is a 66-year-old male without any significant past medical history who presented with worsening jaundice for 3 days. In addition, he has lost 8 kilos in the last 6 months. There was no fever, no abdominal pain. Physical examinations show markedly jaundice. There was no sign of chronic liver disease. Abdominal exams show hepatomegaly without palpable gallbladder. Initial blood tests show total bilirubin level of 8.6 milligrams per deciliter and alkaline phosphatase level approaching 300. The initial ultrasound upper abdomen show mild dilatations of bilateral intrahepatic duct as shown in this slide. CT upper abdomen was scheduled for determinations of the exact locations of the bile duct obstructions and also for further characterizing etiology. On the coronal CT in this video, you will notice the hepatomegaly, the bilateral intrahepatic duct, and the dilatations of the common bile duct with abrupt narrowing here in the distal one. You notice that the pancreatic parenchyma was relatively unremarkable, and there was the prominent size of the main pancreatic duct here in the neck to proximal body. These still images highlight the area of abnormality in the abdomen, indicating distal bowel duct obstruction without demonstrable mass or stones. So the first ERCP performed at outside facilities show normal ampulla. Unfortunately, we didn't have the cholangiograms for review, but they said that the bile duct was dilated approximately 1.5 centimeter in size. They obtained some sludges during balloon swab, and they encountered some resistance at distal duct. So the plastic stent was inserted, and the patient was referred to us for further evaluations. At our center, the bilirubin was decreasing to 1.3. The alkaline phosphatase level was nearly normalized, and the serum tumor marker CA19-9 was within normal limits. So we first began with standard ERCP. The cholangiograms show 1.5 centimeters abrupt area of narrowing at distal common bile duct, causing upstream dilatations of the common bile duct and bilateral intrahepatic duct. I think it would be hard to say that it is irregular because the building process of the contrast was not well opacified in this area. So highlighted in this red arrow. So given very distal end of the common bile duct, relative low sensitivity of standard blood cytology, and the fact that he already underwent first ERCP with stenting. So we decided to go straight to cholangioscopes for visual inspection and to obtain tissue diagnosis in order to maximize the diagnostic yield from these sessions and, if possible, to avoid unnecessary third ERCP sessions. I will show you the video of that procedures. So after assess that the previous sphincterotomy was wide enough, we inserted the cholangioscopes using freehand technique. After we got in, the lumen here was centralized. The water was slowly infused for optimizations of the visualizations. You will notice some difficulties here for maintaining the scope positions in such a distal lesion like this. So here, after we got the scopes to be stabilized enough, we began the examinations in the distal area, just below the cystic duct insertion, which would be on the left-hand side of your screens. And during gentle withdrawal, here at 12 o'clock, you will see the mass-like intraductal lesions containing dilated and tortuous mucosal vessels. We slowly and take a closer look in the area and do a gentle withdrawal, and you will see the irregular area just underneath that. There was some spontaneous blood flow. You notice some friabilities here, the bleeding, just a very little gentle touch of the cholangioscopes. So here you will see the circumferential area of the infiltrative tumors. After that, we perform the targeted biopsies using the spy bite. We get several pieces of them, but during the procedures, I think the pieces of the specimen was rather small. So we did perform additional tests, the fluoroscopy guided intraductal biopsies to maximize the diagnostic yield. The procedures went uneventfully, and the patient was discharged on day 2. There was no immediate complications. The result of the ERCP guided tissue acquisitions, both methods comes out. From cholangioscope, we got strips of bile duct epithelium with mild atypia on the background of acute inflammations, blood clot, and fibrin. From fluoroscopy guided intraductal biopsies, we got the tissues indicating moderately differentiated adenocarcinoma. So at this stage, the patient was diagnosed with distal cholangiocarcinoma The CAT scan you saw earlier indicated that he is a resectable case, so we consulted HPB surgeon and he underwent Whipple operations. The pathologies from surgical specimens show moderately differentiated adenocarcinoma. There was the metastasis foci in regional lymph node, and there was a positive margin in the posterior surface. So now he is receiving the adjuvant chemotherapy. To summarize, I show you the case of distal pharyngeal carcinoma in non-PSC setting. On cross-sectional imaging, the cause of obstruction is still uncertain. The tumor marker was normal. These particular cases highlights diagnostic investigation of distal bile strictures in negative imaging study. The cholangioscopy characteristic of malignancy, and finally the usefulness of direct and fluoroscopic guided intraductal biopsies. I think I would have time more for your Q&A, and thank you for your kind attention. Thank you.
That was very nice, a lovely presentation. And Nontali, do you have anything to add to that before we open to questions?
Yeah, thanks, Manat. That was very nice. I think we can. Well, I've talked to Manas about, maybe we can talk about the difficulty in performing spyglass cholangioscopy in distal CBD. We can talk about the yield of the cholangioscopy directed biopsies compared to fluoroscopic guided biopsies. I think we can talk about that. As far as the things that I want to add before we start discussing all these issues is that I think the unique thing about this case is that the ERCP was performed at an outside hospital who did not have the ability to perform EUS to evaluate distal CBD stricture, because based on the cross-sectional imaging, you can see that the intra and extrahepatic ducts are diffusely dilated, suggesting that the stricture is downstream somewhere in the distal. And without clinical presentation of acute cholangitis, if I were to take care of the patient, I would probably choose to go with EUS for the evaluation of distal duct before going in with the RCP. However, EUS is not available throughout the country. So in that situation, they would have to go in with an ERCP. And I believe that their initial suspicious was a CBD stone because of some clue on the initial imaging demonstrating some sludge in the gallbladder or something like that, which, I think this is something that we can talk about as well. Yeah.
Well, I think those are really relevant questions, and it came to my perspective as well, that the first few things was that the use of SPY after a stent has been placed, the issue of SPY bite, as you mentioned, and the yield. Now, I know there's a new generation, and maybe the other mentors can chip in here, about the new SPY discovery bite, which is a bigger diameter bite, which might give us a better yield, and we can talk about that as well. But it's interesting that when we sat together, I think Nanti, you were part of the consensus group on indeterminate strictures. The use of SPY was, of course, a very important modality. But what you have shown in this case is that you've used it to a very good, very quick, very early on in your algorithm to determine the stricture. Yes, I think US FNA might have helped, and you can see that from the surgical specimen, it was not a clear resection. Do you think EUS might have prevented the Whipple and proceeded to adjuvant chemotherapy before the Whipple? Do you think that would have helped you with doing that prior to the operation?
Yeah, Ryan, if you look at the data, I think that there was a study, a couple of studies actually. One, the most recent one was probably from NAM. assessing the utility of EUS before performing spyglass cholangioscopy in the absence of mass on cross-sectional imaging. And as it turned out, that EUS was very helpful. It could prevent unnecessary spyglass evaluation in about 60% of patients in that series. Although it's a small series, that the patients about 40, at the end is 40, and all the patients presented with jaundice without mass on the CT scan. So definitely EUS is helpful when the CT scan or MRCP doesn't show any mass lesion. As far as the ability of the EUS to detect the extension of the tumor, let's say, for example, if we were to do an EUS in this case, and I'm sure we would see a mass lesion in the distal duct based on that cholangioscopy. I think we can help determining the invasion of the lesion outside the duct within that area, definitely. Yeah. As far as a small lymph node that got discovered in the surgical field, that I'm actually not sure where the lymph node is located. But if it is within the vicinity of EUS, around or adjacent to the distal CBD or even along the CBD, I'm sure that we will be able to detect that small size of lymph node, which may be missed by the CT scan.
Yep.
Yeah.
One last thing is the yield from your spy bite. I mean, this is, the data from India and all. I just, it's much higher than what it is in real life. And it's interesting that you made the diagnosis on a regular, biopsy. So it just shows that sometimes the usual biopsy might work better than the spy bite, than direct visualization.
Yeah, I think it's actually very good that you pointed this out, because usually when we do a spy bite, we would also look at the size of the tissues that we would get. And it's been my experience that I always got like very small pieces of tissue. Yes. And many of you, please comment on this. And I believe this particular patient is actually my colleague who did the procedure. And she felt the same way, that the tissues that she's got from the spy bites were very small. So she decided, rightfully so, to go ahead with fluoroscopic guided biopsy. And the other reason she did that was because this is a very distal lesion. And, technically, fluoroscopic guided biopsy of a very distal lesion, I think it's a lot easier and can be performed as well in adjacent to spy bite. I think Chris and a couple of people have questions. Yeah.
Yes, go ahead. Yeah, Chris.
Hi, Nontali.
Hey, Chris.
Hi, nice manners. I just want to ask, because typically, a distal CBD stricture, we don't think of cholangioscopy as the first option for the reasons that you have mentioned. It's hard to stabilize, but the other thing also is that there was probably no certainty that you might be able to get the spy scope through a stricture, in which case you would have to back off, and quite a lot of expense with the yield. What made you sort of think about doing a cholangioscopy in this particular case?
Yeah, you're right, Chris. And we have talked about this before we presented this case. We knew that we were going to get Manas, and I knew that we were going to get a lot of questions about the decision making here. We pull out the spy very early on for a distal lesion. And, I would have to tell you, though, that generally for a distal CBD stricture management and diagnostic sequence, we don't do spy as an initial diagnostic tool. We generally start with EUS if the patient doesn't have any cholangitis that needs drainage. But if the patient has cholangitis that needs drainage, obviously we go with ERCP with biopsies and brushing. This particular patient, I think it's that there's a little bit more detail that we didn't really bring that out during the presentation. This patient was actually seen by a surgeon before he came to us, and there was a question about a possibility of a mass lesion in the distal duct based on the CT scan, which we couldn't really demonstrate that quite well on prior ERCP. So the surgeon basically said, you know, if we can get them the direct visualization and the tissue to kind of help differentiating between a polyp or a malignant mass, because they were thinking that there might be a little bit of a lesion there based on the CT scan that they saw, but we didn't really see it on the imaging here. So that's really the main reason why we decided to go in with the cholangioscopy, which is not something that we would normally do. Yeah.
Very
Thank
nice,
you. And you did indeed
presentation.
see the math.
Right. Yeah.
Yeah. Thank you.
Can I have some
Yeah,
comment?
definitely. Pardon. Yeah.
Okay, yeah, very nice. And I think that it's for the most distal lesion in the bile duct like this, doing the spyglass is very challenging. I like to show our experience as well. We have the same experience with all of you, that with the most distal lesion, probably fluoroscopy guided biopsy in our group, it gets higher yield than the spyglass guided biopsy. So similar experience to that, yeah. And in some case, that is kind of like maybe chance to be mass forming or even nodule forming. We with the US guided biopsy play role very well. Just want to show confirm your findings and also share my experience. Nice case.
Yeah, I think it's always nice to look at the size of the tissues that we're getting and sort of determine right there if we need more tissues or if we need bigger tissues. And if we have a way to get bigger tissues, then I think we can just try to do that as well.
I think Ben raised his hand, Ben.
I
right?
know, Ben is moving his body, raising his hand, like getting ready to comment. Please, Ben.
Well, thanks, Nonthalie and Manus. That was a great case. And yes, I'm ready to go. Ready to go. I think a few points. I agree with all of your discussion about EUS first normally, but I think what you've demonstrated is that as we get better at this, we can visualize strictures in the distal duct better than we used to. And I think with the high quality imaging of the digital scopes, it can be highly effective. In essence, you had made the diagnosis on the cholangioscopic picture, and we know that our visual impression of a lesion with the vascular pattern and those frondy papillary projections, really you had the diagnosis. So even in the, say your histology was negative by whichever modality, given the essential double duct sign on axial imaging and your cholangioscopic pictures, I think you had a diagnosis. And my only other comment, and because we know that cholangioscopic appearance is as accurate, if not more accurate, than spy bite biopsies alone. And my final comment is about the spy bite biopsies. I think it's really important when we do them and we send them to the lab that we tell the pathologist that they're spy bite biopsies, that they are extremely small, because you know you can look at the jar sometimes and actually not really see any tissue. So they need to be forewarned that the tissue they're looking for and that they need to analyze is extremely small.
Well, one question I want to ask you guys, in your practice, when you do spy bites, do you always or sometimes do fluoroscopic guided biopsies in addition to spy bites? Ben?
Yes, I would normally do that, Nonthalie. I would normally do that still. I think in this setting where you have a distal lesion and it was a papillary frondy lesion, as others have said, that's the time you're more likely to obtain a positive diagnosis. I think the cholangiocarcinomas higher up the duct, which are a scirrhous lesion, where what you're really doing with the biopsy, if it's a tight stricture and it's a lot of fibrous tissue, you're really just jamming the open transpapillary biopsy forceps into the base of the stricture, not necessarily in the stricture. And I think that that can be more challenging, but I would always double down and do transpapillary biopsies.
Okay.
Ben, you know, the idea of biopsy, I mean, it kind of defeats the purpose of SPY bite. I'm just for argument's sake, when you're going to go and back up with a regular biopsy. So that's one. But do you think when the stricture is higher up, it's actually quite difficult to manipulate a regular biopsy forceps up the channel? So do you remember the days of the wire-guided biopsy, which Cook came out with? I don't know. It's kind of lost its role. It's which I thought was a good device, and I've always waited for a wire-guided biopsy device.
Yeah, I think, Ryan, look, I must say that transpapillary biopsies, I've never been an avid fan. And I know that colleagues of mine in Brisbane strongly support them and say that they get a diagnosis all the time. Well, I must say that I've struggled over the years. Again, I think mainly it's for that point that I make, that to open the forceps, you have to be distal to the stricture. Then you jam the forceps into the base of the stricture. And as you know, they always come at that same angle. It's very hard to sample different parts of the stricture. It always comes up and you end up biopsying the same point.
Yes.
So I've not been an avid fan. I think the value of cholangioscopy is that you visualize and you get a visual diagnosis. You can manipulate a little more. The offset is that they're small. However, so therefore, I don't think that then backing up with transpapillary biopsies is a waste, because sometimes you can be lucky because of the larger cup on the forceps.
Well, one last if there's any other questions, but one last question is, when you use the criteria by SPY, if you see now you've got a stent in there, so you could argue that a lot of the criteria you see on visualization might be impaired by the previous stent. And when you look at the breakdown in the data, they say that the abnormal vascular pattern is not as sensitive as we would have thought, because it looks irregular, it looks like a cancer, but the data is not coming out that way either. So in the end, it's still going to be tissue. So I don't know if Dongwan or anybody else wants to, chip in there, please.
Ryan, yeah. I mean, you brought up an important point, which I want to ask Ben about, because although there is, good correlation between visual impression and eventual histopathology, would your surgeons be willing to move on just a visual impression? If, for example, in this case, if the biopsies had come back negative.
Yeah, look, Chris, I think that's a tough one. I think in some cases they would. I think based on that, and Ryan, you're right. The challenge with having had a stent in, I think interpreting the vascular pattern becomes more challenging, no doubt about it. But in many situations in our tertiary centres, the patient arrives, like in your case, already having had an ERCP and a stent. So that's just life. We have to deal with that. The difference here is that you've got a circumferential papillary frondy mass, right? Those changes that you clearly demonstrate, they're not from a stent. Having said that, Chris, we would still do everything possible to get tissue. And in this case, with a controlled bile duct with a stent, we would have proceeded to EUS.
Yeah.
If I add some comment, and I also have a question regarding the visual impression. Our group actually reported more than 20 years ago the cholangioscopic appearance of bile duct tumors and benign strictures, and we reported the value of tumor vessel in predicting the malignancy. But on those cases, not like this. We need to see the naive bile duct epithelium, not smudged by stenting, even not smudged by, we prefer not to cross any guide wire or tube or stent before observing the stricture. If we do that, this is already distorted image. So we cannot be confident with the positive predictive value of this kind of smudged appearance. So definitely we need a biopsy if we have this kind of image. We cannot tell with this image. I do not have the typical tumor vessel image here, but if you look at refer the already reported articles, then the appearance is quite different. And my question to this case is, you mentioned that this case showed positive on posterior side. What do you mean by posterior side? The lesion looks like in the distal part of the CVD. It is intrapancreatic CVD. And when you say posterior margin, is it retroperitoneal margin, posterior side of the pancreas? Which area is it? Dr. Manus?
Manas, are you?
Yeah. I think I had to review with that about the posterior surface, but usually we oriented the anterior surface to the lumen, so it would be the surface that attached to the pancreatic part, but we need to confirm again, because normal orientation here from the surgical specimen and to the lab, the posterior should indicate the surface that attached to the pancreas, I think.
So posterior, you did the pancreatic duodenectomy, right? So
Yeah.
this means if the posterior surface is involved, that it is already infiltrated into the pancreas, and also it is already infiltrated into retroperitoneal side. If that's the case, probably CT scan will detect the extent of the tumor.
Yeah, I think this would probably mean there is some serosal seeding beyond the serosa of the duodenal part of resection. But as far as the CT scan, we didn't really see any tumor invasion or retroperitoneal lymph nodes and things like that at all. Having said that, though, generally a CT scan from an outside hospital is a thick cut. So there is a possibility that if we were to get a thinner cut, we might have seen something. And again, EUS could have helped had we done the EUS before proceeding to cholangioscopy.
Okay.
Yeah.
Okay. If no other questions, thank you very much from Thailand, and we move on to India. I'd like to introduce Dr. Malay Sharma. Is he online? I hope he is. He's a good friend of ours, very avid endosonographer from India. I've been to his conferences many times. He's a man who can identify many vessels known and unknown to mankind on EUS. And I always take great pleasure in listening to him as he pursues and reinvents the atlas of EUS. So Malay, if you're there, please go ahead and introduce your fellow.
Sir, good morning. Sir, I'm Dr. Shivanshu, and I'm doing fellowship under Dr. Malay Sharma at Aryabhat Hospital, Meerut, India. So, sir will be joining in a while. So, shall I start, sir?
Where is your sir? Where is he? Is he hiding in the back or?
No, sir. He's in OPD. He's just coming, sir.
Okay, no worries. You please go ahead, and I'm sure Malay will come in and add to the whole presentation.
Sure, sir. So, I'll be talking about antegrade rendezvous from the second part of the duodenum. So, a brief word about the history. The first US-guided cholangiogram was done in 1996. Subsequently, the choledochoduodenostomy and transgastric intrahepatic biliary drainage was done in 2001 and 2003 respectively by Giovannini. And first EUS-RV was done by Mallory et al. In 2004. So EUS rendezvous is basically a type of EUS-guided biliary drainage. EUS-guided biliary drainage can be transpapillary or transluminal. So in transpapillary, we have rendezvous and antegrade stenting. In transluminal, we have hepaticogastrostomy and choledochoduodenostomy. So EUS-RV is basically a salvage procedure for the failed ERCP. So traditionally, PTBD is basically used for the failed ERCP as a salvage procedure, but it comes at a risk, comes with a cost of high adverse effect, which include bleeding, bile leak, dislocation of the external catheter, and recurrent infection. But facility for both should be available because most of the time US RV can't be done, like in sick patients or with the patients with coagulopathy. The advantage with PTBD is that right ducts of the liver can be accessed with ease. So indication of the antegrade RV are difficult biliary cannulation. If the bile duct cannot be cannulated even after the pre-cutting, tumor invasion of the papilla, periampullary diverticulum, and contraindication include the intervening blood vessels if the patient is in sepsis or have a coagulopathy, or if the bile duct is too small to puncture to be visible on the US. So there are basically two stations. First is from the stomach and second is from the duodenum. And actually there are three sites. First is from the transgastric puncture, we can access the intrahepatic biliary duct. And from the D1, we can access the extrahepatic biliary duct. And also from the D2, but with the short scope position, the extrahepatic biliary duct can be accessed. So this is the comparison of route. The position of the scope will be straight while doing a transgastric puncture to access the intrahepatic biliary ducts. And the scope will be stable. Guide wire maneuverability will be difficult because the distance the wire will be traveling will be long between the access point and the papilla. The needle direction will always be in the distal portion and the distance to papilla is long. Risk of bile leak is low. When we puncture from the D1 portion, the risk of bile leak is high and the scope remains stable. But the needle direction goes towards the hilum. The wire will be moving towards the hilum most of the time. Problem with the D2 is the scope is not that much stable when you're doing the puncture from D2. Guide wire maneuverability is very easy. Needle direction will be towards the papilla. Risk of bile leak is comparable to the D1. So these are the fluoroscopic images when the puncture is made from the transgastric route. Second is from the D1. This is from the D2. So here we can see the position of the scope is in push position, but it is shortened and the puncture site is D2. Scope is very much unstable. So to increase the stability, we need to move towards the right side. And guide wire maneuverability is very easy because the distance negotiated is very less between the papilla and the biliary puncture site. Needle direction will always be towards the distal end and distance to papilla is very short. Risk of bile leak is not that high because the puncture is made through the pancreas. This is the papilla. So why D2 is being favored? Because the distance is small between the biliary access point and the papilla. It provides a favorable trajectory and there is less chance of kinking and looping of the wire. More care is necessary when we are puncturing through the transgastric route because most of the time we tend to puncture above the G junction or at the G junction. That has to be taken care of. So whatever be the site, the guide wire has to be placed along the greater curvature while withdrawing the scope. So it does not hamper your vision while we are doing duodenoscopy or ERCP. Ivashita also suggested that puncture from D2 using a short position is the first transduodenal route. And technical success rate was 100% when he did in the 10 patient. In another 10 patient, he punctured from the transgastric route in 4 patient and from D1 in 5 patient. The relative technical success rate was only 66.7%. Coming on to the technicalities of the procedure, the position of the scope should be between D2 and D3. Roadmap of the puncture site should be clear before puncturing. To increase the visibility of the needle, high frequency should be used, depth should be minimized, and focus should be optimized. We tend to use contrast with methylene blue. Not only it will provide the fluoroscopic confirmation of the bile duct, but also the endoscopic confirmation of the bile duct puncture because the dye will be coming out of the papilla. Needle sheet should be taken out before the apposition or before the puncture because once you oppose the papilla, the needle sheath won't be coming out that easily. Minimal number of the punctures should be used. While executing the puncture, the body position should be towards the right side to prevent the fall of the scope into the stomach. We use 19 gauge puncture needles and with a wire of 0 to 5 inch. Guide wire is sufficiently advanced into the duodenum. So after passing the guide wire into the duodenum, two things can be done. The biliary cannulation via the duodenoscope can be performed along the wire or over the wire. So if you are opting for over the wire cannulation, the wire has to be grasped with the snare or biopsy forceps and taken out through the accessory channel of the side view scope, over which the tome or cannula is deployed. So this is the comparison of the cannulation techniques. So over the wire cannulation, cannulation is basically easy with if you are opting for over the wire cannulation technique, but the procedure time increases and guide wire withdrawal is another problem. Most of the time Terumo is being used. Terumo is a soft hydrophilic wire. So taking it out of the accessory channel is a problem some of the times. It tends to get released in the working channel. So over the wire cannulation is reserved when the papilla is spastic, if you are not able to do the along the wire cannulation. So these are the troubleshoot and the precaution we need to take. So if you are using 19 gauge needle, the wire we should use should be 025 rather than 035. Because if you are manipulating the wire through the needle, if it is a thick wire, then it will have tendency to get friction against the needle and the hydrophilic coating will get lost over the wire. It will lead to the retention of the foreign body in the bile duct. So do not withdraw the wire which is already advanced, as there is chance of shearing the hydrophilic coating leading to the retention of foreign body. Always leave a large amount of the wire to make at least 2 loops into the duodenum, or the wire should go beyond the ligament of Treats into the jejunum. This is the comparison of wires which we use. So ready focus by Terumo, torque transmission is very good, but withdrawal is not that good. With VisiGlide, everything is favorable and the procedure can be done safely. So after passing the wire, the scope along with the needle is withdrawn under fluoroscopic vision while the assistant advances the wire. So we have to support the scope while it leaves the mouth, as if the tip falls, the wire may get dislodged. Always do the along the wire cannulation. Not only help in visualizing the correct angle of cannulation, but also the first wire opens and straightens the distal obstruction. However, if we are opting for over the wire cannulation, always use triple lumen or large hole cannula, which allow the second wire passage, as it may lead to creating a fistula. This was the case series. These are the earlier studies in which we can see there was no, not that much high technical success rate was there. It was around 50 to 70%. But with the time, with the passage of time and gaining in our experience, the technical success rate has been risen to more than 90%. The common complication which we face are exacerbation of contrast, pancreatitis, abdominal pain, hematoma, and bile leak. So there was a review article of 15 studies which reported a technical success rate of 81% and a complication rate of 10%. There was also another article published in Digestive Endoscopy in 2016, which reported 65% technical success rate for transgastric puncture and 87% for extrahepatic biliary duct puncture from D1 and D2 both. Shah et al. Also said the main reason for the EUS RV failure was the difficult guide wire manipulation. So when intrahepatic and extrahepatic approach was compared, it was seen that there was a high post-procedural pain and longer procedure time and longer hospital stay when the puncture is made from the transgastric route. Technical success rate were similar. So these are the conventional procedure available for the biliary drainage. ERCP is widely available and has a relatively low complication rate, but it is not feasible in the case of inaccessible papilla. PTBD is conventionally traditionally used for as a rescue therapy for the ERCP failure, which comes with a high complication rate and can't be used in if the patient has ascites. Broad horizon is available with the EUS. We can do hepaticogastrostomy, choledochoduodenoscopy, internal drainage in the same session of the failed ERCP, but it is not that widely available, and there is no standardized algorithm yet. So this was a case in which the patient came with the complaint of biliary colic and bilirubin was high and patient was in cholangitis. We did EUS in which we can see there is a bile duct, intrapancreatic infraduodenal portion of the bile duct, in which there is a stone is there in the distal CBD and needle is coming out at 1 o'clock. Air bubble could be seen in the duodenal lumen. I'll play the video. So when the bile duct was confirmed, puncture was made, and you can see the needle goes through and through the CBD. This was just to confirm that we have punctured the bile duct, and when we withdraw the needle, both walls are moving. This actually confirms that the needle has gone through the CBD. Here you can appreciate it. I will play it again. See, both the walls are moving while withdrawing the needle. This is another video in which the small amount of the agitated saline was placed just to confirm that we have punctured the CBD and the bubbles start coming out into the duodenal lumen. So after we have punctured the CBD and we are sure about it, so we insufflate the CBD with the contrast in methylene blue. So this is being done here. You can appreciate that the bile dust is distended with the air bubbles and the contrast. These are the corresponding fluoroscopic images of the same patient. In first, we punctured the bile duct. We did a cholangiogram. It showed a filling defect at the proximal CBD. In the second image, we can see that guide wire is being passed through the papilla. In third image, we can see that the duodenoscope was deployed and the second wire was introduced into the papilla. This was along the wire cannulation was done, and finally the drainage was achieved after placing the stent. We roughly do around 3,600 ERCP per year. So we did 5 cases of USRB since last year. Indications were the failed cannulation, and 2 cases in which 2 cases were of the periampullary diverticula, and 2 were of the choledocholithiasis with cholangitis. In one patient, the papilla could not be localized. CBD was punctured from the D2 in all the cases. Guide wire was successfully passed in D2 all the cases. We did not face any complication as of yet. So this is it. Thanks. Session is over.
So, Malay, thank you. It was a lovely.
We are done with the presentation of Dr. Shivanshu. So I would like to add on 2 points, and I don't have a long presentation. I have just 2 slides to explain what I want to say. Just 3 slides, and so we would present what are the problems with based integrated randomly. So we are facing some problems in integrated, what are the technical problems we can face. So I would say reaching duodenum. We have to reach duodenum, and when it is difficult phase, the difficult phase, we have to reach preferably to second or third part of duodenum. Because it is in this second or third part that you can take out the needle. You cannot take out the needle out of the scope in the first part when you are shortened it. Because when you are shortened, you are afraid of slipping out and you want to keep the knob up close to the duodenal wall as much as possible. So you reach distal duodenum, move the scope down, knob down, take out the needle, fix the needle, adjust the needle, and then you shorten the scope. So this thing is very important because the needle must be fixed before you start shortening the scope, because when you are shortening the scope, without shortening, you cannot get a direct access. You want a direct access, so you want to shorten it. So reach second part of duodenum, pull it back, rotate whole body slightly to the right, move, take out the needle first, and then move it up, shorten, and sort of fix it. Sometimes I need my assistant to hold the scope in this position because now I'm going to puncture. Occasionally, once we are torquing the scope slightly, to get the right side of puncture, we slip out, but doesn't matter. We'll go all over again. Now is the time when I'm about to take out the puncture, I want to increase the visibility of the tip of the needle. Because in this case, as also in other cases where we do FNAC, but in this particular case, the visualization of the tip of the needle within the bile duct is the most essential step. So what do? We will see that the CBD max zoom, that is 2 centimeter, not 8 or 10, max zoom. We use the highest frequency, and then we will make the screen slightly black. Sometimes you can decrease the dynamic range of the machine, so you see just black and white. And this is important because within the pancreas, you may not be able to see the tip of the needle because pancreatic ecotexture may be somewhat like the ecotexture of the tip of the needle. You cannot see. It is only within a dilated CBD that you will see the tip of the needle. Sometimes you may not see it while it is moving through the pancreas. So you will apply tissue harmonic imaging. You will not apply compound imaging, highest frequency, and you will adjust the focus to lie where the tip of needle you expect to reach within the bile duct. And then you puncture. On the side, there is a picture that shows killing 2 birds with 1 arrow. What I am talking about, 2 birds are both walls of bile duct with lumen in between. And once you are through with this needle, then you move it in and out, and you can see the bile duct wall moving in and out. Then you slowly withdraw. If the lumen is very wide, then you have no problem. You will reach within the bile duct. But if the lumen of bile duct is very narrow, say 2 or 3 millimeter, as was seen in this case, then you need to be very precise, very much within, at the time of puncture, within the central part of CBD, so that you go from one wall to the other wall and then pull back. And pull back to the point that you see only one wall moving. And then you can inject air. So you sure in that, you will have a gut feeling with experience, you will understand what is going on. And then you to inject agitated saline. Agitated saline has micro bubbles. Bubbles will create problem. how will the bubbles go? The bubbles go if by chance you are trying to irrigate, but the needle has been removed and you are pushing in contrast, then large bubbles may go and they make the problem, they make it difficult to see. But if you are injecting micro bubbles, that will not be difficult. So one of the things is sometimes you can take the stellate out and just irrigate the needle and out with normal saline and then puncture it without a stellate. So that when you inject agitated normal saline, you do not inject more air into the pancreas or into the bile duct, because that air is the enemy. So microbubbles are not enemy, but bubbles are the enemy. And how do you create microbubbles? You just shake the normal saline with some amount of air, take the air out, and then you inject. You can inject contrast. Again, injecting contrast should be agitated contrast mixed with methylene blue as a salvage procedure. If you fail, then you can see from inside where the methylene blue, where the blue bile is coming out from. Flush the contrast, pass the guide wire, already explained by Dr. Shivanshu. One more point, devil's advocate is to distend CBD or not to distend CBD. We have found out that in some of our cases, when the CBD was dilated, the guide wire will go up. So then what did we do? We just sucked the bile out, and then the CBD collapsed and the guide wire went down. In one or two cases, smaller tricks was that we could follow the stone and we punctured just below the stone. The guide wire had no room except to go down. So if the CBD is dilated, one of the trick can be suck the bile so that the guide wire goes down. So I think I have explained it all, and if there is any point for discussion, I would be willing to answer this question. Couple of things more. One or two things more is that why antegrade rendezvous? Why not? Because at our center, I am not very sure of the wire, my ability to pass in wire from the stomach, or my ability to pass in wire, first taking it to the hilum of liver and then pushing it down. So we have a couple of failures. But since we started practicing this antegrade rendezvous, we have fair quick success within 5 minutes in all cases in antegrade cannulation.
Okay, that was very nice, Malay. It's great to have you with us. Thank you for that very interesting technique. I just want to ask one or two things. One, you use the size of the distal bile duct determine your success rate. Now, you're saying a 19 gauge needle in a 2 millimeter duct, and your success rate is going to, it's going to be difficult and I know your technique is to skewer the bile duct, but my natural thought process is once you skewered the bile duct, there's obviously going to be a risk of bile leak if your procedure fails. So I have a concern when you have a very narrow distal bile duct with a 19 gauge needle.
This is a very valid question. My answer to this is that the risk of antegrade puncture, transpancreatic antegrade puncture, is as much as an FNAC. So if FNAC is going to cause problem, that bile is not going to come back into pancreas. No. So that much morbidity we have to accept if we are converting a procedure into antegrade transpancreatic puncture.
Fair enough. Fair enough. Okay. What is your algorithm, Malay, and your place to decide on rendezvous? Do you attempt pre-cut? how many minutes do you give? Do you have a time frame for you to then decide on EOS rendezvous?
No, we have the standard attempt. We attempt 55 cannulation, otherwise 5 minutes, 3 attempts at touching papilla. If we fail, we resort to pre-cut. If the guide wire passes in the meantime, then we will place if passes into pancreatic duct, even once pancreatic stent, we never take the guide wire out, and we try again after 24 to 48 hours. But sometimes we anticipate that even after 48 hours, we are going to fail. In those cases, we will proceed with antegrade rendezvous in the same session. So if you ask, out of 100 cases, our failure is say about 10% in first attempt. So we will repeat out of those 10, we will be successful in most of the cases after time, after about 48 hours. And there were all these 5 cases were not exactly failures. We anticipated we will not succeed in future.
Okay, and last question from me, Malay, is, you mentioned about looping the wire in the duodenum. When you do that, then you are forced to go alongside the wire for cannulation, which is the easier way. But if you fail that, then you have to try and railroad, which would mean you'd have to pull back the wire to try and catch the end of it to railroad it out to the scope. Would that be correct?
Yes. Railroading, when it comes to railroading, I try to avoid railroading as much as possible.
Yeah.
What I do is, I will do an over-the-wire pre-cut and see. So most of the time, I would consider over-the-wire pre-cut and extension a safer procedure compared to railroading, because the railroading, the inside wire is very stiff. And my worry, to tell you frankly, is that I have only 1 centimeter entry through pancreas coming through papilla. So can this stiff wire shear all the way, from that short passage? So, but if we do railroading, we are very slow, because you are coming through the upper part of duodenum and then going into. So you can create some sort of a fistula or tear it theoretically. So practically it has not happened, but I don't want to make a tear through the pancreas either way.
Okay. Any other questions?
Yeah, hi Malay. It's Nantali here. Good to see you. And a very nice technique presented by Shivanshu. My question is this. So I know that you have your algorithm, as you just mentioned. What I'm wondering is that, what are the cases that you would advise not to use this technique? For example, patients with distal bile duct lesions or ampullary lesions. Is this technique applicable to those types of cases?
We won't be doing USRV in the patient who are very sick. Suppose if the patient came with a cholangitis and papilla is not accessible, we would still go for PTBD. That's why I said it earlier that both the techniques should be available at any center. USRV can't be done if the patient has coagulopathy, if there is hypotension, patient is quite sick and can't tolerate the anesthesia. So we would like to skip those cases. If we have time, if patient is stable, we can still try it.
So the ampullary lesion or distal bile duct lesion,
it's not audible, ma'am.
Can you hear?
Pardon me, please.
Can you hear me okay now?
Yeah.
Okay, yeah. I was asking about cases with
it's going away. It's going away again.
Oh, is it? Can you hear?
Yes, ma'am.
Okay. Do you find it more challenging doing this type of procedure in patients with distal bile duct lesions or ampullary lesion?
If the distal bile duct lesion is extending to the mid CBD portion, then it can't be done. If it is localized to the ampulla or to the terminal part of the CBD, then it is very easy because the wire negotiation will be very simple. We can manipulate the wire quite easily. But if the lesion is extending into the mid portion of the CBD, then it will be a problem, sir.
Okay, thank you.
You know, I had a chat with Mark Giovannini some time ago, and it's very interesting that his view, and it's anecdotal, his view is that he has gone away from US rendezvous. He feels the complication rate and morbidity is high, but I think, if you look at the data, and maybe Malay or anyone can see that the data came out in the early 2012, 2015, but the data it's kind of fallen out of favor in the last year or two. And I think that could be because of a bit of the morbidity associated with it. But then again, Malay, you've shown your technique very nicely. I think in the right hands, it's still a good technique, but there's still some reservation about this procedure. If anybody else would like to say, Pradam or Dongwan, please.
Yeah, sorry. Yeah, can you hear me?
Yes.
Yeah, I just want to show my background. That's now I'm in a beach. Yeah, already. Yeah. And also, thanks, Malay, very much for your nice technique. I think that this technique is very important, particularly in the bile duct stone case, because at this time in the bile duct obstruction, particularly in the distal bile duct obstruction, if we fail ERCP, we can go for USB drainage. But for ERCP, for common bile duct stone, if we cannot get in, that's also the trouble. So if we still need the techniques of the US guided rendezvous, and it's very nice to hear your technique today. Very nice. Yeah. You see the beach, right?
Okay, I think my beach is better.
Oh, really? Oh, no. But yeah.
Okay, anybody else before we close this and move to the next presenter? Dongwan, anything to say? Chris? Yeah, Dongwan.
Hello, Malay. Can you hear me, Malay?
Yes, sir. You are audible, sir.
Okay. Congratulations. I would say this is uniqueness of Malay's team. Malay-like system. He always try to accumulate his experience and knowledge and try to make some system or algorithm and try to educate us. I think he's doing very great. Yes, as Ryan mentioned, if we try to do rendezvous, sometimes we can experience some bleeding or some dirty field in the duodenal lumen. So some people try not to use this technique these days, and we cannot see many data these days on specifically on this technique. But if Malay's team accumulate his own experience and make some algorithm and teach us, then we can use this technique more frequently in the future. And one comment to Malay is when you are trying to use air bubble, you mentioned that you are using normal saline and just shake it and inject it. I think with that method, I think it's okay, but we cannot create, small bubble, homogeneous bubble. So we are using three-way and connect two syringes on either side of the three-way and inject like this and like this. By this maneuver, you can create relatively even small micro bubbles inside the syringe. And sometimes we try to use contrast when we are trying. I did not have much experience on this, but in some groups, when they try to puncture intrahepatic biliary radical, if they do not see the course of the biliary radical clearly, then they inject contrast into the biliary tree to see clearly the course of biliary tree.
Wow, that was interesting, Dongwan. You've made me very agitated trying to figure it out, like the agitated saline. But thank you very much. I think that was interesting. Thank you, Dongwan. We move on. Thank you, Malay. It's great to see you and your team. We move on to Sandeep. Sandeep, thank you for your nice comment just now. We'd like to invite Sandeep Latakia, a good friend of mine from Hyderabad. Sandeep, you're no stranger to us, so I have really nothing much to say about you, but it's great to have you here. Please introduce your trainee.
Thank you, Ran, and good afternoon, good evening, everybody in the panel. It's good to have a blend of people from Australia to Singapore, Korea, Bangkok. We saw the beach. And I am not in Hyderabad at the moment. I am in Delhi. And this is the first physical meet during COVID times. And I didn't want to lose the opportunity of meeting my friends physically. And that's why I saw that the list is a little small because some of the people are attending physically here in a US conference going on. So moving forward, let me introduce my friend, my younger colleague, Azimuddin Haja, a very bright young star in AIG. What we have is a very interesting case. I think we can discuss that later. Let Azim present the case and we'll take on the questions and comments and suggestions thereon. Azim, over to you, please.
Thank you very much, sir. Honorable Chairman and all the distinguished faculty and all media colleagues. Greetings from Hyderabad and thank you very much for this opportunity and having us. Coming to our patient, she's a 16-year-old lady. She had Whipple surgery 10 years ago for a locally advanced periampullary carcinoma. And 5 years later, she presented with cholangitis, where percutaneous attempts were made and serial catheter exchanges were done over a period of 1 year, after which she remained well. After 5 years, she developed symptoms of cholangitis again. And this presentation was for 2 months when she has developed fever, itching, and her liver functions shows an obstructive pattern with an elevated bilirubin, total counts, and elevated alkaline phosphatase. An MRCP was done to have a roadmap approach, which showed a large calculus, almost 3 centimeters plus in the CHD. The patient was offered EUS intervention and agreed to it as percutaneous radiological techniques had already been tried and the patient wanted to avoid surgery. A linear EUS screening done, which showed that bilateral IHBRD and the segment 3 duct was identified. Then with the 19G needle, this duct was punctured by obtaining a Doppler-free window and contrast was injected. Initially, the wire, as you can see, went towards the periphery and this was redirected here, as you can see, in the EUS towards the hedge stricture. And then we managed to pass the wire deep across. And the cholangiogram then revealed this large filling defect, suggestive of a stone. We then proceeded with the step of a 6 French cystotome, which was cauterized over the guide wire to create a tract. And this is the fluoroscopy of the cystotome going deep into the bile duct. And then we proceeded to deploy the SEMS. The SEMS we used in this case was fully covered, as this was a benign indication and it was 8 centimeters long. And this is the fluoroscopy where the SEMS is being deployed. And this is the gastric portion. We left around 3 centimeters of the fully covered SEMS, and you can see a lot of sludge coming out. And as this is fully covered and it's a benign disease, we left a double pigtail 7 French 12 centimeters pigtail stent to scaffold the SEMS in place. And serially fluoroscopy was done. As you can see, this to follow up the opening. Gradually, the mid portion of the SEMS started opening up by week 1, and the CT scan post procedure revealed confirmed the portion of the SEMS in situ. And by 3 weeks, the SEMS that we felt sufficiently opened up. We then brought back the patient, and the first endoscopic procedure was attempted. A adult scope, a 9 mm or a slim 5.4 mm was unable to negotiate the mid part of the SEMS. This we felt was because of this angulation and a narrowing in the mid part of the SEMS. A guide wire was left into the bile duct in situ, over which a spyglass cholangioscope digital was passed. This is the fluoroscopy. And intrarectal laser lithotripsy was performed. Here you can see the blasting of the stone fragments under cholangioscopic vision. And this was through the channel with the duodenoscope. However, still large stone residue remains. And then a mechanical basket was passed. Because of the large size of the stone and the angulation, this failed to engage this large bile duct stone. And we managed to retrieve it back. And then we placed the nasobiliary tube with the tip just above the stone and subjected the patient to extracorporeal shockwave lithotripsy, a couple of sessions, where we obtained complete fragmentation. And then we proceeded to do a biliary dilatation of the HJ stricture up to 15 mm. And then with the help of a biliary balloon trawl, we proceeded to push all these well-fragmented stone fragments distally across the now dilated HJ site into the proximal jejunum. And the occlusion revealed complete biliary clearance. Then the HJ SEMS was removed. Here, fluoroscopically, you can see, and this reveals the gastric stoma site of the HJ. This was then cannulated with the ball tip, and the guide wire was again passed deep to the HJ. You can see it has nicely gone deep into the jejunum, and a 7-strand double pigtail stent was placed. We brought her back after 3 months. She was doing well. We proceeded to remove this double pigtail stent, and we injected contrast, and still she remains symptom free and the occlusion is normal. A few highlights in this case is US intervention coming to the rescue to obtain a temporary biliary access and drainage, and challenges of a benign biliary disease like what we faced here in a backdrop of a surgical altered anatomy, and then successfully tackling them endoscopically, avoiding surgery. And using all modalities at hand, like we started with the SPY digital cholangioscope, we tried mechanical, and then we achieved complete stone clearance with the aid of extracorporeal shockwave lithotripsy. The message is never to give up, because establishing biliary continuity, relieving the obstruction, and clearing the stone is crucial for this patient to avoid repeated cholangitis and secondary biliary cirrhosis. And you have to try all the modalities in the toolkit. So where US guided intervention in biliary large stone disease stands as compared to a laparoscopy approach or a double balloon enteroscopy approach or antegrade rendezvous EUS approach, I would like to just give over to my mentor, Dr. Sandeep sir, to take it over from here. And thank you.
Thank you, Azim. That was a wonderful presentation. And it's open to the audience. Ryan is sleepy, he's yawning, but it's okay. So this was a very challenging case. As you must have observed, that this patient had a periampullary carcinoma and she survived 12 years. In between, she had an episode of cholangitis related to hepatojejunostomy stricture, which our standard algorithm is to do a PTBD and put a catheter inside and keep upgrading every 3 months for a total of 1 year. So at that time, 15 mm diameter of the edge stricture was achieved. And then she was left on follow-up and she was doing reasonably okay. 6 years later, now she comes back again with stricture and symptoms, and MRCP confirmed a large stone. She was not willing for surgery, not willing for another round of PTBD for a year. And that's when we decided, let's try our skills on EUS, which we have learned from all of us, each other. And so we placed a fully covered 8 centimeter long, 10 millimeter diameter Tai Wung stent, which has a flare in the stomach. So it is not the usual long stent, which is a partially covered geobore, but this is a fully covered stems, which we kept in for about 3 weeks to allow the stoma between the liver and the stomach wall to oppose and anastomose and kind of become adherent to it. And then we tried breaking the stone. So we tried everything in the book. We thought that we can pass a slim scope and do laser lithotripsy, but the angulation was almost 90 degrees. So even a regular and a slim scope could not go in the forward-beam scopes. Then we passed an ERCP scope, a duodenoscope, and then passed a SPY through that and did laser lithotripsy. It looked quite good endoscopically through laser, through the cholangioscope, and we thought that we broken the stone. But when we took a cholangiogram, it showed still large fragments. Then we thought, okay, let's try the balloon and push it down or use a mechanical to take out the fragments. Still now nothing worked. So then we took help of our ESWL colleagues. We have a strong department who breaks all these heavy burden stones in pancreas. So this we did it for the bile duct. And normally we place a nasobiliary through the transpapillary route, but since in altered anatomy we placed ESWL catheter. 2 sessions of lithotripsy were given. And then cholangiogram confirmed that the stone fragments are broken. So at that time, we cleared up the bile duct. And then we can't leave this stent permanently because it's a benign disease. So at that time, once the duct was totally cleaned up, we removed the fully covered stent and placed a plastic stent trans stomach through the liver into the anastomotic side into the jejunum as a long double pigtail stent, which we kept for 3 months. And then we called her back and removed this stent and checked the cholangiogram, and now she's doing fine, at least now for 3 months of the stent-free period. We hope that this does not come back again, but at least we have a stoma in the stomach from which we can enter and do some kind of a biliary work if the stoma remains patent for a long time.
A few questions, Sandeep. Very nice presentation. Number one, do you think your algorithm would have changed with the new short SPY scope, which allows you percutaneous intervention with the new SPY scope, the short scope? Now, that's number one. Number two, why did you use a fully covered? Is it because you wanted to remove it? What about if it was a geobore? How long is it safe to remove it? So say if you took it out within 2 months, could you still remove it endoscopically? And the third question is, you have a stricture in the distal end, which probably was the start of the problem. Are you worried about restenosis? Would you want to keep a stent in a longer period and dilate it frequently, because she's going to restenose again, most likely?
So taking the last question first, I don't know what's going to happen. So she had a 15 millimeter dilatation previous time when she had a indwelling site, which kept the stoma patent for next 6 years. I don't want a stent to hang in this old lady, and as she keeps growing over, we keep doing stent exchange every 3 months. I think that's not the way to probably follow up. So that's why we removed the stent at 3 months time and hope that she remains cholangitis and biliary obstruction free. Having said that, I'm also not very sure what will happen to the stoma. Will it stenose or will it keep patent? Available is just personal experiences from everybody, but that's generally in the end of life care or a benign disease where things are, where stricture. No, so I believe that stricture is reasonably opened up, and time will tell us how we're going to move forward. Very interesting one. I think we didn't have that, and our radiologists were not keen, and the patient was not keen for a second PTBD procedure because she had it inside for 1 year, and that's why we could not consider that.
But Sandeep, if it was a geobore, would you be comfortable removing it? Would you be comfortable removing a geobore?
So a fully covered stent, generally at around 2 weeks or so. This again Mark's experience, which I have copied from him. He says at 2 weeks the stoma happens and it gets fibrosed. The liver gets adherent to the gastric wall. And we had our own experience once of a patient who had a borderline resectable tumor where we had placed a partially covered geobore. This is a fully covered stent. So fully covered can easily be removed. A partially covered will anchor in, and that's the geobore. The fully covered is not called geobore. It's just called a fully covered from thigh wound.
Right. So that's why you use
partially covered.
That's why you used to fully covered.
That's
so
right.
what
So
about
our aim was to remove it off. Our aim was to err on the side of 3 weeks because I was not sure. This is the first time experience, and that's why we did that. What we did.
Any other questions?
Ben has opened his mouth.
Yeah, just a comment. Great case, Sandeep, and I appreciate that. And I was interested that your fully covered stent didn't move with all of that manipulation. I really found that interesting, particularly when you had the basket right around. You were trying to grab that stone, and you were able to skillfully then close the basket and withdraw without pulling your stent out. So that was really interesting that the fully covered stent didn't migrate. One must expect, I would have thought over time, that the gastric opening of your fistula would close up really quite readily, wouldn't one think?
Yeah, so that's one fear that we have, that the gastric end may close with passage of time, but hopefully then the bile goes down the edge side and that keeps it patent. And we did this manipulation at 3 weeks, and that's when the stent fully opens up, allows all our devices to go across the stent. We didn't want to do it upfront at the first go because then nothing is fixed as yet. The fibrosis has not happened, stent has not opened up, and we can have more complications. So this was all discussed with the patient that this is what we are going to do. And I had this mental plan ahead of us that this is how it's going to happen. And we just hope and pray, and maybe I'll educate all of you in times to follow that what happened finally to this patient when we meet physically. 6 months, right? Chris, what do you say? 1 year down.
Well, we like you, we have started also doing live workshops. So I'm here in Sabah. So hopefully we'll have all of you over very soon.
Okay.
Ryan, could I just ask Sandeep, really nice case from you and Azim, illustrating the principle that a fully covered stent can form a nice passage and keep it open, and using the double pigtails to anchor it as well. My concerns really about doing this on a wider scale is with the potential risk of cholangitis from side branch occlusion. Have you had, what's your incidence of that occurring in the cases that you have done? And do you have a way around that? Does the stent you use make a difference? Maybe Korean stents with lower radial force versus the wall flex. Does that make a difference?
So that's a great comment and question, Chris. Am I audible?
Yes.
Am I audible? Okay. So we had the same fear too, Chris, and we have only very limited experience of using a fully covered stent in a benign condition, and it's more of a theoretical risk of blocking the side branches and causing a problem. So we were anticipating that in case that happens, we'll pull it out earlier, but fortunately it didn't happen. Although we used a 10 millimeter diameter stent, which would have definitely blocked the side branches more aggressively, because the depth was not 10 mm, it was about, I think, 5 or 6 millimeters. So it would have stretched the side branches more in the left segment 3. But fortunately, though, that did not happen.
I wonder if maybe the force of the tailwing stent compared to a wall.
So this has somewhat of anti-migratory flange at the gastric end compared to the standard geobore, which has less of flap. But I think they're coming out with another version which has a more bigger flange at the gastric side, so that we need not leave all that long gastric length segment in the stomach. And that's why we kept doing that repeated X-ray imaging to see that the stent has not migrated. And in fact, once we got a CT also in between to recheck things that the stent is in right position, has not got sucked into the liver or the peritoneum.
Sandeep, from your experience with hepatico-jejunostomy anastomotic strictures, how do you manage that? I mean, what is the duration of dilation and so on? Can you educate us on that?
So Ryan, I will take what has been learned from the enteroscopy view of method of dilating these edge strictures. When they go by an enteroscope and reach this anastomotic site through the lumen, the anastomose is dilated up to about 15 or so. And then they place a plastic stent, which is again removed after a finite period of 3 or 6 months later. We followed the same logic, now this time approaching it antegradally rather than retrogradely. And there also, from Dr. Kira's experience, which I have come across, is that they also dilate about 15. They have a higher threshold of using an enteroscope to manage these kind of strictures. And they dilate about 15, remove those stones, and just do not place any stent. So we imagine the same logic should work in an antegrade approach.
Okay. Thank you. Any other questions before we move on? All right. Thank you very much, Sandeep. That was excellent. Thank you, Azimuddin. Fantastic presentation. We move on to our Korean friend, Professor Dongwan Seo from Seoul, Korea. He will be talking to us with his trainee on a case on pancreatic cystic tumors. Professor Seo, please.
Thank you for giving me this opportunity. I'd like to introduce my fellow. He is Dr. Sunghyun Cho. He graduated Inje Medical University College of Medicine, and then he joined Assam Medical Center and received the internal medicine residence training in Assam Medical Center. After that, he joined in Department of Gastroenterology. He is now senior fellow in our pancreatic biliary endoscopy area. He is specializing in this pancreatic biliary disease and ERCP and EUS field. Today, he is going to present the EUS guided TTMB for pancreatic cystic tumor. Dr. Jo, please.
Okay, good evening. I'm Sunghyun Cho, a clinical fellow in Department of Gastroenterology, Assam Medical Center, Korea. It's my honor to chance to present our study. The title I present is Endoscopic Ultrasound Guided Through the Needle Microprocess Biopsy Improves the Categorization of Types of Pancreatic Cystic Lesions. The incidence of pancreatic cystic lesions, PCLs, has been increasing due to increases in the use of high-quality cross-sectional imaging. The strategy of management and surveillance for PCLs varies depending on their type, because each type of cyst has different malignant potentials. Mucinous cysts, including IPMN and MCNs, have the potential for malignant transformation. Meanwhile, asymptomatic non-mucinous cysts, such as serous cyst adenoma, SCA, and asymptomatic non-neoplastic cysts, such as pseudocysts, do not have malignant potentials and thus do not require further lifelong follow-up and management. Therefore, precise diagnosis of pancreatic cyst is very important to avoid unnecessary evaluation or unnecessary surgical resection. There are many guidelines for diagnosis of PCLs. However, to date, there is no gold standard for differential diagnosis of pancreatic cystic lesions. The combination of various diagnostic modalities, including cross-sectional imaging such as CT and MRI, endoscopic ultrasound, EUS morphology, and EUS-guided fine needle aspiration for cystic fluid analysis and cytology, shows a relatively good diagnostic yield of PCL. CT, MRI, and EUS morphology are sensitive for detection of PCL, but are not very accurate for distinguishing mucinous from non-mucinous cysts. The addition of cystic fluid cytology and CEA analysis increased the diagnostic yield for differential diagnosis between mucinous cyst and non-mucinous cyst. Despite the relatively good diagnostic yield of conventional modalities, the accurate categorization of types of PCLs is still challenging. EUS and cross-sectional imaging have limitations for differential diagnosis of PCLs. Analysis of CEA in cystic fluid cannot differentiate between IPMN and MCN and was shown to be inaccurate in differentiating between low-grade and high-grade dysplasia in mucinous cysts. Cytology showed suboptimal sensitivity because of scanty cell counts. This conventional approach remains inadequate for differential diagnosis of specific types of pancreatic cystic lesions. It is reflected by recent two studies. In one study, in histologic review of surgical specimen of resected pancreatic cyst, resection rate of benign cyst was more than 30%. In another study, unintentional resection rate was approximately 20% for non-mucinous pancreatic cyst. Therefore, additional tools are needed to differentiate mucinous versus non-mucinous cyst, IPMN versus MCN, and benign cyst versus cyst with high-grade dysplasia or invasive carcinoma. Novel modalities have been introduced to overcome the limitation of conventional modalities in terms of diagnosis of PCL. Specifically, US-guided through the needle imaging, such as cystoscopy and needle-based confocal laser endomicroscopy, CLE, has shown promising outcomes for improving the diagnostic accuracy of PCL. However, tissue is still the issue. For tissue confirmation, endoscopic ultrasound-guided through the needle biopsies, USTTMB, using microforceps, referred to as Moray microforceps, was introduced. Tissues obtained from the cystic wall or mural nodule using USTTMB can provide a histologic diagnosis that was not available in imaging modalities. In our center, we have performed USTTMB for differential diagnosis of type of PCL. In this time, we introduced our study about USTTMB. In our study, we evaluated the efficacy and safety of USTTMB. The prospectively collected and maintained USTTMB database at Assam Medical Center was reviewed to identify patients with PCL who underwent USTTMB between January 2019 and January 2021. USTTMB were performed at the discretion of the endosonographers when the malignant potential of PCL could not be completely excluded. Thus, the result of USTTMB was expected to change the strategy of surveillance and management of PCLs. The exclusion criteria were as follows: extrapancreatic cystic lesions, highly suspected of pancreas cancer based on cross-sectional imaging and tumor markers, or the longest diameter of PCLs on EUS imaging was less than 2 centimeters. The definitions of terms were as follows. The technical success was defined as the ability to obtain gross specimen by USTTMB. Diagnostic yield was defined as the ability to obtain specimens that are adequate for pathologic examination for the characterization of the specific types of PCL. Specimens not sufficient or adequate for pathologic examination were referred to as diagnostic failure. Adverse events were defined as all procedures related to adverse event which developed within 7 days after procedure. The presumptive diagnosis was defined as the diagnosis of cyst type based on the combination of EUS morphology, cross-sectional imaging, and analysis of CEA and amylase lipase levels in the cystic fluid. The primary outcomes evaluated in this study were as follows: technical success, diagnostic yield, and adverse events. In addition, factors contributing to diagnostic failure and the discrepancies in the diagnosis between USTTMB and presumptive diagnosis made by combination of conventional diagnostic modalities. Two experienced echosonographers performed all procedures. Before the procedure, the patients were placed under conscious sedation using intravenous administration of midazolam and meperidine, and were administered prophylactic antibiotics, third-generation cephalosporin intravenously. EUS was initially performed using a conventional linear array endoscope to evaluate and record the characteristics of the cyst, including the size, morphology, location, and presence of mural nodule, septation, and solid component. A microforceps, which has less than 1 millimeter outer diameter, was passed through the 19-gauge needle and advanced into the cyst. The targeted lesions were cystic walls, septation, solid components or mural nodules. Let me show you the procedure. After microforceps was passed through the 19-gauge needle and advanced into the cyst, microforceps in the pancreatic cyst were opened and gently pushed against the target lesion, closed, and then pulled back to see the tent sign on the EUS. After confirmation of tent sign like this image, microforceps were pulled back to obtain specimen. If the tissue grasped by the closed jaw of microforceps was too large to be retrieved through the 19-gauge needle, the microforceps and 19-gauge needle were simultaneously retrieved from the cyst, like this video. After confirmation of the presence of tissues on the jaw of microforceps, the tissues were deposited in the formalin jar. Microforceps passed through the 19-gauge needle or needle passes were carried out multiple times until 3 to 4 visible fragments of tissue were obtained. The specimens were processed as routine histologic samples and reviewed by a pathologist. In this figure, H-staining staining showed mucinous epithelium with low-grade cytologic atypia. It is consistent with IPMN low-grade dysplasia. I'd like to explain the results of the study. After excluding 2 patients with extrapancreatic lesions, a total of 45 patients were included in this study. The baseline characteristics of the patients and PCLs are summarized in this table. The mean size of PCLs was 45 millimeters. The PCLs were located in the head or uncinate process in 10 patients, body in 6 patients, and tail in 25 patients. Of the 45 cysts, 11 had mural nodules on EUS image, and 28 had septations. The median follow-up duration was 24 days. The procedural outcomes are presented in this table. The median number of 19-gauge needle passages to PCL was 1, and the median number of microforceps biopsies per patient was 4. EUS-TTMB was successfully performed in all cases. Historic diagnosis of PCLs was made in 37 of 45 patients. Diagnostic yield was 82%. The most common histologic diagnosis from EUS-TTMB was IPMN. During follow-up, the rate of adverse event was 7%, including 1 patient with intracystic bleeding, which was self-limited on Doppler image, and 2 patients with acute pancreatitis, which was improved after conservative management. During follow-up, 10 of 45 patients underwent surgical resections. Of them, 1 patient had a diagnostic failure. After excluding this patient with diagnostic failure, 9 patients who underwent surgical resection were evaluated to compare between EUS-TTMB and surgical pathology. The histologic diagnosis of EUS-TTMB was concordant with that of surgical specimens in all patients who underwent surgical resection. Patients who showed diagnostic success were included in a subgroup analysis to compare the results of EUS-TTMB with pre-summative diagnosis made by combination of EUS morphology, cross-sectional imaging, analysis of CAN and amylase lipase levels in the cystic fluid. As shown in this table, 10 patients showed a discrepancy between EUS-TTMB and pre-summative diagnosis in terms of characterization of types of PCLs. In the 10 patients with discrepancy, the results of EUS-TTMB changed the strategies of follow-up and treatment in 4 patients. In 3 patients of these 4 patients, the pre-summative diagnosis of PCLs were PCL with malignant potential, but EUS-TTMB showed no malignant potentials. In the remaining 1 patient, the pre-summative diagnosis was SCA, but EUS-TTMB showed IPMN with malignant potentials. We analyzed the factors contributing to diagnostic failure. There are no significant differences in the diagnostic yield according to presence of septation, size, targeted lesion of biopsy, and location. However, there was a significant difference in terms of mean number of microforceps biopsies per session. The diagnostic yield was significantly different between those whose number of visible biopsy specimens per session was more than 4 and those whose number of visible biopsy specimens was less than 4. In summary, for categorization of PCLs, EUS-TTNB showed a high rate of technical and diagnostic yield and a low rate of procedure-related adverse events. A smaller number of visible biopsy specimens per session was associated with diagnostic failure. History diagnosis of EUS-TTNB was changed the diagnosis in 10 patients in terms of categorization of types of PCLs, and changed the therapeutic strategy in 4 patients. In conclusion, EUS-TTNB showed high feasibility, high diagnostic yield, and an acceptable safety profile. EUS-TTNB as an adjunctive to other modalities may improve the characterization of types of PCLs. Guidelines for PCL is expected to be changed according to the historic diagnosis of EUS-TTNB. Thank you for your attention.
Thank you, Dr. Zhou. Now, this presentation is open for discussion. Is there any question or comment on this study?
Can I ask Dr. Zhou, when you gave an adverse rate of 7%, complication rate of 7%, you said that the yield is higher if you do more than 4 biopsies. So did the adverse rate go up with the repeated number of biopsies, or was there any correlation between adverse events and the number of passes?
Thank you for your comment. Of course, as you mentioned, the more biopsy process and the more chance of adverse events will be increased. But in our analysis, there is no significant differences in terms of adverse event between according to the number of biopsies in this analysis.
And so when you advise, would you be concerned with a 7% adverse event? Like, what is your, when you take a consent from a patient, our consent rate for adverse events from EUS is less than 0.03%. Now we're saying that this procedure can give you a complication rate of 7%. Is that acceptable?
Yeah, we think it is acceptable because even though there is a 7% of the adverse event, all of the adverse event was mild, and it was absolutely resoluted by conservative measurement, and average days of hospitalization days was only 2 to 3 days, and there was no life-threatening adverse events in this analysis.
I think the complication-wise, much safer than ERCP. ERCP has much higher rate of complications, and also sometimes we can experience severe complications. This is much safer than ERCP.
Yeah, yeah, actually that's right. I am Pradum Chai. Yeah. So, hi, Dr. Cho. Congratulations for your successful presentation, and also Professor Dongwan. But I agree with Ryan that the complication rate from TTNB from microforceps may be a little bit too high, even though majority of the reported complications are just mild pancreatitis. But to your experience, do you have any way to reduce chance of the pancreatitis in this procedure?
This is actually our first study and the first experience of this new device. So this includes the learning period, the experience also. And we are accumulating more data, and nowadays we are becoming more comfortable, and the complication is not that our major concern. In this analysis, after this study, I also saw some cases after biopsy of cyst wall, some cystic fluid leaked out, pericystic area, but those lesions are not malignant lesion, benign adenoma or mucinous or sometimes serous lesions. So even though there is some pericystic fluid leak, it was it did not cause any serious problems. We will accumulate more data and try to analyze it and try to answer to those questions in the future.
Dongwon, when you have a multi-septated lesion, how do you then do this procedure? Do you go through the septa? How do you decide?
From our experience, when you try to target the septum, the yield is not that high. When you get some tissues from the septum, the pathologists say that there's not much cells on the septa on this biopsy specimen. So nowadays we are trying to target the opposite side wall. Opposite means opposite to the scanner. So then the yield is relatively high. Puncturing the septum is not an issue. With 19-gauge needle, you can puncture the septum. So you can target the opposite wall.
Yeah, thank you, Dr. Cho and Dongwon. We certainly need to do studies like this because despite all of the work over the last 20 years, 25 years, we still struggle with diagnosing and stratifying pancreatic cysts, and they're so common. So it's an ongoing problem. I don't want to constantly focus on the complications, but it is interesting. The point that I picked up was the number of times where you had to actually, in obtaining the specimen, remove the whole needle and the forceps out of the cyst and then re-puncture the cyst. Was there any sense that that was associated with a greater risk of complication? Because that goes against our principles somewhat, doesn't it, as far as needling cysts?
Yes. Originally, this device was developed after just one puncture with 19-gauge needle. Through the needle, we can get several biopsies. But sometimes if you get a large chunk of tissue in the biopsy forceps, then you cannot retrieve the forceps inside the 19-gauge needle. So in those cases, initially I tried to remove those forceps through the 19-gauge needle, but it stuck. So in those cases, I tried to remove the biopsy needle forceps simultaneously. And then if I look at the specimen on a Mohs macroscopic examination, there is a relatively large chunk of tissue at the biopsy process. And we try to re-puncture it. But from our experience, we do not see that actually increase the risk of the complications. My major concern was initially when we first tried to get the tissue from the cyst wall, if we close the cyst forceps inside the cyst, sometimes we cannot see any material in the biopsy forceps. To avoid that, I pushed very hard to the cyst wall and pushed the cyst wall outside of the cyst control and tried to get some amount of tissue. I think that motion actually created some injury in the pericystic area, pancreatic parenchyma, and that actually was the cause of pancreatitis after this biopsy.
And may I have a question, Dongwon?
Yes.
Okay. Yeah. Thanks for your suggestion. And after you do the biopsy from the cystic wall, do you also aspirate cystic fluid completely out, or just leave it there?
Try to. If the cystic fluid is large, then we aspirate some amount of cystic fluid for analysis, and then do biopsy, and then try to aspirate all the remnant cystic fluid, because this is actually this can create some contamination of cystic fluid because of our manipulation. So if it is possible, try to remove all the cystic fluid at the end of the procedure.
Okay. Yeah. And Dr. Cho, thanks for your nice presentation. I have a question that have you compared between the result of the biopsy and complication between normal cystic wall and cystic wall with thickening or mural nodule. Any difference on that?
Thank you for comment. We did not analyze the differences of diagnostic yield in terms of wall thickness.
Yeah. Because
Yeah,
I think that
we did not analyze.
Wall, if the cyst wall is thick, we have relative safety margin of cyst wall puncture or pericystic leakage or injuring the pericystic pancreatic parenchyma.
Okay.
I envy your sound from beach.
No, you see, he's in the library, but it's very windy in the library.
This is the fact.
All right. Well, thank you so much, Dongwan. It was fantastic. Thank you very much. We move on to the next presentation. I think the next person on the block is our comrades from Australia. Professor Ben Devereaux, thank you for joining us. Please introduce your fellow.
Is Mehul on the line? I can't. Oh, here we go. Yeah, good. Thank you, Ryan. It's great to be here with everyone and to catch up. And I certainly hope we can catch up in person soon. Mehul is the Advanced Pancreaticobiliary Fellow at the Royal Brisbane and Women's Hospital. So Mehul has been training in ERCP and endoscopic ultrasound. And I thought we should present our multi-centre series, which predominantly Australian and some centres that you're involved with in the Asia Pacific, looking at drainage of pancreatic fluid collections in the hot LAMS era with the hot Axios. This was a multi-centre series that Mehul will go through, but the important thing is that it started, the data collection started from when the individual units started using the device. So just as Dongwan said in the previous study, we went through the learning curve phase. These data actually collect that initial experience as well. Thanks, Mehul.
Right. Hi, good evening. Can you guys hear me?
Yes.
Right. I'm sorry, I'm just getting my presentation up. Just in a moment.
So
right, I'm hoping that you guys are able to see the first slide, the title slide.
No,
not yet. Not yet.
Not yet. Right. Okay. I'll just try and screen share again. How about now? Can you guys see now?
Yes.
Right. So hopefully this should work. Right. Hi. Good evening from Australia. Thanks for introduction, Professor Devereaux. My name is Mehul. I'm one of the Interventional Gastroenterology Fellow at Royal Brisbane and Women's Hospital. And thank you for giving us the opportunity to present at this forum. So I'll be talking about management of pancreatic fluid collection in the LAMS era. And I'll be starting by talking about a case presentation and then talk about the study that Professor Devereaux just mentioned, and then also try and look at some more contemporary evidence for some of the questions around LAMS. So starting with the case presentation, this was a 60-year-old gentleman who had presented with acute pancreatitis to a peripheral hospital in Queensland, Australia in July this year. On presentation, he was hemodynamically stable with systolic blood pressure of 160, although he was a bit tachycardic with heart rate of 100 and afebrile. His past medical history was significant for having had multiple surgeries in the past for bowel adhesions and had hypertension. In the table here, I've displayed some of the more relevant laboratory results at presentation to hospital. As we can see, the lipase on admission was elevated at 4,000 units per liter in keeping with his acute pancreatitis. He had neutrophilia with neutrophils 25.8. Hemoglobin was normal, and his other liver function tests and renal function tests were within normal limit as well. So this was a CT scan that was obtained on day 1 of admission. This is an arterial phase scan, which shows edematous pancreatitis with interstitial stranding. However, even at day 1, there was some differential enhancement that was notable on the CT scan in keeping with a necrotizing process. So this gentleman was initially managed with enteral nutrition as tolerated and analgesia. However, by about a week into his presentation, he started developing fevers, tachycardia with very high inflammatory markers up to 400 of CRP. A CT scan was repeated at day 10, which unsurprisingly showed formation of pancreatic fluid collection around his pancreas, and the pancreatitis now was a lot more evident to be showing necrotizing process. He initially was treated conservatively with broad spectrum antibiotics. However, another 10 days into his admission, he started clinically deteriorating again with fevers, worsening pain, and worsening inflammatory markers. His CT scan was repeated again at day 20 from his onset of pancreatitis, which shows a large pancreatic fluid collection measuring almost 14 centimeters on the CT scan on the axial section, as well as some hypodense lesions within the pancreatic cyst in keeping with acute necrotic collection with necrosum and debris. And even at day 20, as you can see on the CT scan, it looks like he had began to form a capsule around his cyst. By now, he had started becoming somewhat unstable hemodynamically, right, with his blood pressure now falling to about 90 to systolic and becoming more tachycardic. At this stage, since he continued to deteriorate despite being on IV antibiotics, he was then transferred to our center for endoscopic management of this cystic fluid collection. So just talking a bit about pancreatitis, as we know, the incidence of pancreatitis seems to be increasing, and the latest epidemiology data from the US suggests that the annual incidence of pancreatitis is about 5 to 35 cases per 100,000 population. The pathophysiology of pancreatitis can be divided into 2 different types. Majority of the patients, almost 80 to 90% of patients, develop interstitial edematous pancreatitis, which is a milder form of pancreatitis and follows a self-limiting course. However, 10 to 20% patients develop necrotizing process with necrosis of the pancreatic and peripancreatic tissue. And necrotizing pancreatitis, as we are aware, is associated with significantly increased morbidity and mortality. It is also important to appreciate that the mortality that is seen in patients with pancreatitis is biphasic. About half of the deaths are generally noted within first 1 to 2 weeks of presentation. And the early mortality is related to cytokine surge and significant systemic inflammatory response syndrome and persistent multi-organ failure. However, a slightly bigger peak and later mortality that is generally seen after 3 weeks since the onset of pancreatitis is often because of infective complication and predominantly infective necrotizing pancreatic collection. It is also important to talk about the definition of pancreatic fluid collection before we start talking about its management. This is a definition that's from 2012 Atlanta classification, which classifies the pancreatic fluid collection based on the pathophysiology of the pancreatitis. The fluid collection that results from interstitial edematous pancreatitis in the first 4 weeks is called an acute pancreatic fluid collection, while after 4 weeks, once it begins to form wall, this collection is called pseudocyst. Similarly, the fluid collection that results from necrotizing pancreatitis and has debris and necrosum in it in the first 4 weeks is defined as acute necrotic collection, while after 4 weeks is defined as walled-off necrosis. Given the proximity of the pancreatic fluid collection to the gastric lumen, there has been a long-standing interest in endoscopic management of pancreatic fluid collection. And historically, attempts at either aspiration or performing a fistulotomy have been documented as far back as 1975. However, it was not until mid-90s when attempts at therapeutic drainage of pancreatic fluid collection endoscopically were attempted using the plastic biliary stents. Further, in late 2000s, the self-expanding metal stents, especially the biliary metal stents, began to be used. However, since the advent of lumen-opposing metal stents in 2013, the whole paradigm of endoscopic management of pancreatic fluid collections have changed extensively. As we are aware, these lumen-opposing metal stents, especially with an electrocautery enhanced delivery system, results in high technical success and significantly shorter procedure duration. These stents also have a special design with a short straddle and quite wide flanges, and as compared to the other self-expanding metal stents, has significantly low risk of migration. More importantly, these lumen-opposing metal stents come in varying diameters between 6 to 20 millimeters in diameter, and the wide caliber access to the pancreatic fluid collection provides for an improved access, not only for rapid drainage of the fluid collection, but also provides us an access to perform endoscopic necrosectomy. So after this gentleman was transferred to our institution, and once his case was reviewed, he was considered for performing a cyst gastrostomy the next day, that is day 21, into his presentation. And in here I've showed some of the images from the procedure that was performed on him. As you can see on the EUS images, a large cystic collection including or involving fluid as well as solid debris was visible on the EUS. A 15 by 10 millimeter hot axial stent was placed into the cyst cavity with evacuation of pus from the fluid collection. A planned lavage and necrosectomy were performed at week 2 and week 4, and eventually at week 5, the axial stent was removed, and at this endoscopy, completion necrosectomy was performed, and the image on the right shows a clean cyst cavity with healthy granulation tissue. At this point, we inserted 2 plastic double pigtail stents to reduce the risk of reaccumulation of fluid within the cyst, especially since the cyst had not completely collapsed. This was a CT scan that was performed on this gentleman 2 months later. That is last month, which shows complete resolution of his pancreatic fluid collection with the plastic pigtail stents in situ. So I'd like to talk about the contemporary practice of placement of lamps in patients with pancreatic fluid collection, especially in the Asia-Pacific region. So as Professor Deveru alluded, our group from Brisbane, led by Professor Deveru, performed a multi-center observational study to evaluate efficacy and safety of lamps in management of PFC using the electrocautery enhanced delivery system. As part of this study, all consecutive patients who underwent lamps insertion at 17 hospitals in the Asia-Pacific region were included. Importantly, this study involved all patients from the inception, that is, every single patient from the get-go who had lamps inserted was included in the database. This study included 2 hospitals from Thailand, 1 from Singapore, 3 hospitals from New Zealand, and 11 hospitals from Australia. All hospitals were provided with a standardized data sheet to collect all the relevant variables. This was an investigator-initiated trial with no financial support obtained. The procedural factors, as well as clinical decision-making with regards to the type of procedure or placement of other accessories during the procedure, were left at the discretion of the treating team. Looking at the results from the study, a total of 202 patients underwent lamps insertion from August 2016 to April 2019. The mean age in this cohort was 53 years. As one would expect, alcohol and gallstone were the most common etiological factors for pancreatitis. The average PFC diameter was just over 10 centimeters, and almost half of the collections were infected. The procedural technical success with the electrocautery enhanced lamps was 97.1%, and this was taking into account the early learning curve. The mean procedural time was 36 minutes, and in 3 centers, the average procedure time was less than 20 minutes. The mean lamps indwelling time in this cohort was just over 7 weeks, ranging from 1 to 280 days. About 70 patients in this cohort had lamps placed for walled-off necrosis, and these patients required an average of 1.5 additional sessions for necrosectomy. Clinical success in this cohort was defined with complete resolution of the pancreatic fluid collection at the time of stent removal. The overall clinical success with lamps placement was seen in nearly 89% patients. Importantly, in patients with walled-off necrosis, clinical success was noted in 85% patients. There were 11 patients with post-operative collection, and clinical success with regards to resolution of fluid collection was noted in all 100% patients. It is important to note that only 4.5% patients required additional radiological or surgical intervention after lamps placement. Looking at the procedure-related adverse events, mild deployment of the stent was seen in 7 patients, and all of these happened early in the experience. Minor bleeding and post-procedure fever was seen in total of 5 patients. The delayed adverse events wise, stent migration into GI lumen was seen in 7.4% patients. Importantly, in this cohort, none of the patients had the stent migrated inside the PFC cavity. Stent occlusion and infection and need for an unplanned endoscopy was seen in 7.9% patients, and intuitively, this happened predominantly in patients with walled-off necrosis. Major bleeding was seen in 4 patients out of 202 patients, and all of these cases were because of splenic artery hemorrhage. These patients required either IR guided embolization or surgery. Buried lamps was seen in 2 patients. However, lamps could be relatively easily released by application of APC. Therefore, this large multi-center observational study evaluating the EDS lamps in routine clinical practice suggests that high technical and clinical success can be achieved, and there were low risk of any major adverse events. I would also like to draw attention to a few pertinent questions regarding lamps use in this era and review contemporary literature around this. Some of these questions that you commonly come across is if early lamps placement that is less than 4 weeks is safe, and whether delayed lamps removal is associated with major delayed bleeding. And lastly, do coaxial plastic stents need to be placed? So the question of whether early lamps placement is safe has really been instigated by some guidelines suggesting that lamps placement ideally should be performed after 4 weeks to ensure adequate encapsulation. However, when we look at the retrospective data available in this regard, it doesn't quite stack up with it. For example, in a retrospective series where 76 patients with walled-off necrosis underwent an early lamps placement at a median of 20 days, out of these, 92% cases were found to have at least partial or complete encapsulation. Importantly, when they compared patients who had lamps placed less than 4 weeks than those who had placed after 4 weeks, there were no increased procedure-related adverse events, including perforation. These results have also been replicated in a recent Mayo retrospective series that was published in GI last year, suggesting that placement of cyst gastrostomy in less than 4 weeks appears to be safe. Similarly, looking at the risk of major delayed bleeding with delayed lamps removal, and again drawing attention to our observational study. In our observational study, we found that the mean lamps indwelling time was just over 7 weeks. And despite that, there were no excess major bleeding events noted in our series. Importantly, when we look at the retrospective review of larger cohorts, we find that the cumulative risk of delayed bleeding is in the realms of 3 to 4%, and majority of these major bleeding events tend to take place within the first 2 to 3 weeks. And therefore, the risk of major bleeding does not appear to be related to the duration of lamps placement. And hence, if clinically indicated, it appears safe to leave lamps in for beyond 4 weeks. And lastly, addressing the question whether coaxial stents need to be placed at the time of lamps insertion. In our observational study, we found that lamps occlusion that required unplanned endoscopy intervention was seen in 7.9% cases, which predominantly were in patients with walled-off necrosis. Given that our study was an observational study, a subset of patients underwent LAMS with insertion of plastic pigtail stents or nasocystic drain. And when we compared this cohort to those patients who did not have plastic stents placed, we found that LAMS occlusion was much less common with plastic stents were placed, although this did not quite reach statistical significance with p-value of 0.06. And therefore, it appears that especially in patients with walled-off necrosis, coaxial stents placement at the time of LAMS insertion may reduce the need for unplanned endoscopy. Therefore, to conclude, the management of pancreatic fluid collection and LAMS placement is a complex decision, especially when these patients are quite sick. And a multidisciplinary approach is required, and working along with other specialties to decide the next best course of clinical action. Certainly, the advent of LAMS has changed the paradigm of endoscopic management of PFC, especially the infected walled-off necrosis, which also provides us ability to perform endoscopic necrosectomy. Our contemporary real-world observation study shows that the use of LAMS is safe and effective. The early endoscopic drainage, that is performance of an early cyst gastrostomy less than 4 weeks, appears safe. Our observation study further confirms that delayed removal of LAMS does not appear to be associated with increased risk of major bleeding. And lastly, coaxial stent placement, especially in collections with large burden of necrosum, may provide an advantage. Thank you.
Thank you, Dr. Lamba. Ben, are you there?
Yeah, Ryan.
Okay.
Thanks, Ryan.
Yeah, I think it was a lovely presentation, Ben. Just to start the ball rolling, from your data, it looks like, have you now extrapolated a definite algorithm in management of these cases? So, for example, we all have our own way of doing this: 2 weeks, 4 weeks, whatever. But with your now, you've got a database. Would you be able to extrapolate a definite regime? And secondly, I think, the 7.9% of cases which needed coaxial stents, I think the data now would be more cases. If you do not put a coaxial stent in a walled-off necrosis, you're going to get occlusion much more commonly, I would think. Would you agree with that, Ben?
Yeah, thanks, Mehul, and thanks for the overview of the subject. I felt this was important, even when we did this and when we published it, there'd been a lot of work published on pancreatic fluid collection drainage, and I think in some sense people thought we've got that all sorted. And I think the answer is, for something that's so common, we don't have it sorted yet. To come to your question, Ryan, I think we don't have a set algorithm, and in fact, what I think we do need to do is revisit a consensus statement on this in the Asia Pacific as a group. It's been done in the past, but the remote past, and it hasn't been done in the LAMS era. We still don't know all the answers. For instance, should we be using these expensive devices in all collections? Should we still be using plastic stents which are cheap and can be left ad infinitum in certain pseudocyst cases, etc.? So I think we still need to clarify that, but there's no doubt, as you can see, that use of LAMS is incredibly easy. It's taken a procedure that took multiple steps and it's become pretty well a one-step procedure. And even where Mehul presented the data that the mean procedure time is 36 minutes, I think most of us would agree that actually these days it's a lot shorter than that. And we've had success in pseudocysts as well as walled-off necrosis. As far as putting in the double pigtail stents, I haven't been an avid proponent of that, other than cases of significant residual necrosum. But it's not complex, it's not expensive, it doesn't really add much to the procedure, and I think increasingly that is appropriate. I think that the key issue that comes out of these data are, one, that it is real world, and that it started with, the data collection started with individuals' first case with Axios, and as their experience evolved, that the devices can be left longer than 2 to 3 to 4 weeks, and they can be left safely. And I think that's very important. And the bleeding risk in this series just wasn't borne out to be as high as in other series. So I think we can be reassured.
Any questions from anyone?
Yeah, hi, that was a very nice presentation, Dr. Mahone and Ben, thanks for doing this. And I just want to make a couple of comments, and then I have a question for the two of you. In my practice now, I use LAMS for all types of pancreatic fluid collection, pseudocysts included. For pseudocysts, I don't actually put a coaxial double pigtail plastic stent in, because the cysts collapse very, very quickly, and I can just remove the LAMS out very quickly as well. So I don't think we need to use a double pigtail stent. But for necrosis, on the other hand, I generally put in a double pigtail stent, just because I think I would need to leave the LAMS a little longer. But my question to you both is that it seems that based on your series and the literature, we are now okay to do endoscopic drainage of fluid collection of less than 4 weeks, based on your series and the data that you've presented. My question is that for those collections on the CT scan or EUS, do you see a wall, like a nice wall, or do you just not care about the wall at all and would just put a stent in?
Mehul, why don't you respond to that?
Yeah, so from the literature that I've seen, and also from the practice that I've been involved in over the last year, I think the way to understand this is that the concept that the wall forms after 4 weeks does not necessarily hold true for all patients. And there would certainly be a subset of patients who might take longer than 4 weeks, but also a subset of patients where a reasonable amount of wall forms in less than 4 weeks that would allow us to access it. We have been, when we have come across these patients who have had less than 4 weeks since the onset of pancreatitis and a cyst gastrostomy that needs to be placed on clinical grounds, we do look at the CT scan to try and see if there is some evidence of at least partial encapsulation, and obviously other anatomical factors as to how nicely is it opposing to the gastric lumen. And similarly on the EUS, a wall is, in the cases that I've been involved with, almost certainly appreciable. That may not have been as clearly evident on the CT scan.
Yes, I think Nonthalli, that you want some evidence on imaging that the collection is organising, that it's not just a diffuse peri-pancreatic, peri-gastric fluid collection. So you want some evidence, and some obviously has to be proximate to the gastric wall, as Mehul said. I think if on clinical grounds it needs to be performed, it's increasingly becoming clear that it is safe to do. I think the question is, in that setting, is the LAMS clearly a better device? And probably the answer to that is yes, because of the lumen opposing quality to it, rather than just placing, say, double pigtail stents. But I think we need, the series on this are small, and I think we need more evidence in that regard. And again, it's something that I think we need to come together about to define.
Right. And as you know, that there's always going to be some discrepancy between the images that we see from CT scan and EUS in terms of the amount of necrosis, debris, and wall as well. So do you guys generally do an EUS to assess the lesion, whether or not you can actually drain the cyst endoscopically? Meaning, if you see a CT scan and you're not sure whether or not you have some organized collection, would you do it with EUS again before you make a decision, or would you just go for percutaneous drainage?
No, we would do an EUS, and we've certainly been put in that position where the sense is that it is more organized, and we've gone down with EUS and just seen an amorphous, heterogeneous, awful looking massive inflamed tissue related to the pancreas and the stomach. So we've gone in there to assess with the intention of doing it if indicated, if we get a nice clean pocket. But there have been several instances where we just don't find a clean pocket of fluid or a clean encapsulation, and so pull out.
Okay, got it. Thanks, Ben.
So, Ben, you're absolutely correct. Many times we go down and we see, as you said, an amorphous area with a lot of material, a lot of necroma with very little fluid. And I remember doing one case with Takao, and what he did was he actually injected saline to build up the fluid to drain the collection. So he actually created more fluid because the necroma had to come out, but there was so little fluid that he would actually infuse fluid and then do the drainage, which is, I thought, quite interesting.
Yeah, that is interesting. I think the other thing that's interesting in regular practice, Nonthalea and Ryan, is when you see axial imaging and it looks like a very clean cyst, and you think this is a pseudocyst, right? And you go down and you see an awful lot of intracystic debris at EUS. And I think one of the fundamental issues that we again need to grapple with is how many of these fluid collections are true pseudocysts. And I would put it to you that most of these, the vast majority, are actually walled off pancreatic necrosis. We see an awful lot of debris in these collections. And the Axios works very well in that setting.
From my experience with wall of necrosis, if we do not put coaxial stents in a true wall of necrosis, I find the healing process results, but they form like little cavities which seal off if we do not keep it patent with these pigtail stents. And in a few cases, what I've done is I've actually gone ahead over time to put in nasocystic to lavage. And that was the only way of clearing these necromas, which extend almost down to the renal angle. And that's the only way I could to get some kind of success.
Yeah, I think you're right. I think the other thing for the trainees to understand is, whereas putting a double pigtail stent can actually prevent that necrosion from occluding your lambs, that's not always the case. And I've certainly had cases where I've had an occluded lambs with a double pigtail in and a leash of tissue occluding the whole system. So one still has to be aware in the context of patient's deterioration that it can still be stent occlusion.
Yeah. Okay.
But,
I have a question.
Yes.
Yeah. Okay. Congratulations for your very nice study, Mohan and Ben. I think that to my opinion regarding drainage of the PFC, it depends on the character of the PFC, like your guy discussed. If it's pseudocyst, maybe a plastic stent. If it's a worn, it should be lamps or something that very can drain adequately. And the clinical successes and technical successes in your study are very high. And I wonder that it is just a short-term clinical success rate, or do you already you exclude some complicated wound, for example, wound with extension to the lower abdomen that may require additional percutaneous drainage or something? And all the participants, they do early necrosectomy or they do the nasocystic drainage or whatever. That's all the things that we need to discuss. So probably the technical and clinical successes in this study may be just technical for LAMP deployment and immediate short-term clinical successes. Am I right?
Yeah, look, and you raised the limitations of retrospective data collection and multi-center collection without a prospective protocol. About I think it's about 2/3 of the data was collected retrospectively, and then it switched to prospective as each unit came on board with their ethics approval. We did it that way to capture their first experience, but as you say, that dissecting out those different protocol variations therefore is challenging, and that would require, I think, prospective data and a different study. The management of the fluid collection was at the discretion of the clinician in each unit and based on their disciplinary review panels. So I think that there are issues, Pradam Chai, that need to be dissected out a little further. I think one of the key issues with selecting, do we use a LAMS or do we use, say, plastic stents? I always look at the distal pancreas. How much pancreas is there distal to the fluid collection, and what does the main pancreatic duct look like? That is there a duct disruption that really may require long-term drainage with a plastic stent? But what we've found, even in those settings, is if we put a LAMS in, I think it's the rapid decompression of the fluid collection that actually seals off, in the main, seals off the duct, and therefore you don't get that persistent juice production and flowing from the tail into the cyst. And that's something, again, I think we need to look at long term.
Thank you. Good.
Hey, thank you very much. Any further questions? If not, thank you, Ben and Mahol. We move on to the last talk of the day from my good friend, ex-president Pradam Chai from the beaches of Thailand. He will now do an academic presentation, I hope, with the sounds of dogs, and I heard some cockerels and hens on the background. We'd like you to introduce your fellow.
Yeah, thank you very much. Now I'm not at the beach. I'm moving to a garden. Yeah, that can produce many kinds of fruits that you guys like to eat. Durian, mango, rambutan, whatever, right? Yeah. So may I introduce my current EUS fellow, Dr. Borat Ang. He is my current EUS fellow, and actually he works at the Khao Hospital, Phnom Penh, Cambodia. So he will present one of our case during his training. So Dr. Borat, please.
Thank you, Professor Pradam Chai, for your kind introduction. May I ask the host to be able to share my screen, my slide, because I cannot do it.
Okay, try.
Okay. So. Okay, everyone, see my slide. Good afternoon, everyone. So I am from King Chulalongkorn Memorial Hospital, Bangkok, Thailand. Today I have a case to present to you all. It's about US guide gastroenterostomy to create second outlet obstruction for benign pyloric stricture after transpyloric stenting with LAMS. So here we have a 67-year-old male presented to us with symptom of gastric outlet obstruction. Gastroscopy revealed a benign pyloric stenosis from post-peptic ulcer. We did biopsy and histology shown moderate chronic gastritis with H. pylori positive. So what we did is we have performed 2 sessions of balloon dilation followed by transpyloric stenting with LAMS and steroid injection. The patient was somehow doing fine only when he has the transpyloric LAMS, but when we remove the LAMS, the stricture come back. So after multiple exchange of LAMS, we discussed with the patient and proposed to him a surgical gastrointestinal bypass. However, the patient refused surgery and wanted us to attempt US guide gastroenterostomy. So since the introduction of lumen opposing metal stent, especially the HOT system, surgical management of gastric outlet obstruction has rapidly transformed to US gastroenterostomy. Clinical efficacy of USG shown to be higher than conventional transluminal stenting, with much less invasive than surgical bypass. But the majority of cases were for malignant group. Nevertheless, there is also report on US gastroenterostomy for benign group, showing clinical success rate around 96% and clinical success rate around 84%, with a mean follow-up time of 176 days. Unplanned reintervention rate was around 4.8%. So for our patient, we scheduled a device-assisted EUS guide gastroenterostomy using a nasobiliary tube and 20 mm hot axial system. So I have the video here. So as you can see during procedure, a standard gastroscope can easily pass the stricture through the existing LAMS, allowing us to place a 7.5 French nasobiliary tube into the jejunum. And then we can start to fill a solution mix of saline, methylene blue, and contrast media. Next, we switch to EUS. As you can see, we have difficulty to identify and puncture the target valve, as the filling solution could not stay in the valve loop, because in fact, the stricture site is not here anymore, as we have the transpyloric lamps. So both ends of the valve segment that we want to puncture are wide open. So nevertheless, after 3 difficult attempts, we could finally and successfully get into the desired small valve segment. So we can start deploy the system. So here we have deployed the first flange correctly inside the valve loop, followed by deploying the second flange of the lamps intrachannelly to avoid misdeployment outside the stomach wall. So after fully deploy the lamps, we can see a good flow of blue solution, confirming that we are in the right track. However, at the end of the procedure, one of the previous puncture site had active bleeding. Fortunately, this bleeder gave us some time to finish our procedure first, so we could treat it easily and successfully with 3 standard EMO clips. So here we have 2 lamps for 2 gastric outlets. The patient was doing fine post-procedure. We refit him at day 1 and discharge him home at day 3. At 1 month follow-up, he has no complaint of any symptom of GU, and we perform standard EGD to remove both lamps and place 2 double pigtail stand in the gastrointestinal stomy to keep the track pattern. Learning point from this challenging case, for technical point of view, first, we can see that prolonged GU can cause a very distended stomach. Second, when there is no real obstruction and both sides of the target valve are open, we can have difficulty to keep the fluid inside the valve to dilate it well. So different techniques such as using double balloon EPAS to occlude and continue filling the fluid through the nasobiliary tube, which is what we did, until we have a good visualization that we are in the correct loop before starting deploy the stent. And this case is also a concept of 2 is better than 1 to create a second gastric outlet for this recurrent benign pyloric stricture. So in the future, if the stricture reoccur at one of the 2 orifices, we could have time to go back and dilate it without having patients suffer from symptom of GU. EUS gastroenterostomy was reported with several techniques such as direct puncture, balloon-assisted technique, EPAS balloon, rendezvous, or even retrograde deployment technique. EPAS balloon is a double balloon catheter invented by Professor Itoi. We use it to occlude a desired segment of the valve, allowing us to easily dilate it, and it was reported with 90% of technical success rate. In his report, he also mentioned that we should use hot system to directly puncture as a single-step procedure, avoiding using guide wire that could sometimes push the very mobile small valve away, making misdeployment of the lamps. A summary of EUS gastroenterostomy, regardless technique and etiology, the technical success rate and clinical success rate was around 87% to 100% and 84% to 100% respectively, with complication rate from 0 to 33%, including misdeployment of the stent, bleeding, pneumoperitoneum, peritonitis, abdominal pain, and gastrocolic fistula. So in conclusion, EUS gastroenterostomy could be one of alternative option for benign GU after careful discussion with the patient, owing to its lower invasiveness than surgery and longer durability than enteral stenting. To dilate well the valve loop in order to be well identified on EUS view is very important for successful procedure. So here we have some pitfall of EUHE published by Dr. Nantali. We could have 3 scenarios. So the first one is when we miss the puncture of the valve, but we didn't deploy the lamps yet. This could be due to insufficient distension. So what we can do is to retract the device and repuncture again. Second scenario is when we deploy the first flange outside the small valve because it slipped due to bad visualization, or sometimes we use the guide wire and push the ball away. If this happens, we can recapture the system and pull it back in the stomach, close the puncture site and real-time at the same session or schedule for another one. Third scenario is when we misdeploy the second flank outside the stomach into the peritoneum. This could happen because we deploy the second flange of the lamps outside the working channel. So what we can do is to place the guide wire through the system into the small valve and place a second fully covered metallic stent as a bridge stent. And surgery is also another option for this situation. Thank you for your attention.
Thank you very much, Borat. Nice presentation. Any question or comment from the audience or commentators?
That was very nice, Pradam and team. The issue now of maintaining that fluid when you put a patent intestine, you show it nicely, but it's very difficult in real time to keep the fluid there. Do you have a time frame of how quickly you have to puncture that, because the fluid drains down and then you're into a whole small bowel being opacified, and then you lose that time? Is there a time frame where you feel that the risk is going to be or risk of complication goes up?
Yeah, actually, the case that Borat just presented, this is the only case that we were concerned. For other cases, we have a very high successful rate. We never miss. And how we can do, we have to prepare everything ready. Our scope is in the good position. The lamps prepare ready to puncture, pass through the stomach and the small bowel. And after that, we start infusion of the diluted methylene blue water into the small bowel until it dilated enough. And we need to go very fast, because if you slow, then it might cause some complication, like Dr. Nontali reported in the US journal. But luckily, we have young colleagues who is very fast for pushing all the water in. We ask them pushing. Yeah. So then you see that this case, the landing point, like Borat presented, that because we already placed another lamp to resolve the obstruction in the pyloric ring, right? So then we flush water in. All the water try to come back. So that's why we failed for 2 or 3 times before we got the successful placement of the lamps across the small bowel.
Is positioning the patient helpful?
All cases we do in the prone position. Yeah.
Okay.
Pradam, why not use a irrigation pump, which is what we've started doing for a while now, because then people don't get tired, and when you turn the pump up high, it really works pretty well.
Oh yeah, that's a good idea, but then we have to buy another pump, right? And we have
just borrow from another room for half an hour or whatever.
Oh, you meant the pump that we use?
The irrigation pump, yeah.
I'm not quite sure that it's quicker than manpower to push that. Yeah, we do really quick. Yeah. I don't know why we can compare in the future.
To give it a try, yeah. We used to sort of depend on sort of 2 people pushing, but they get a bit tired after a while sometimes. And with the irrigation pump, you just step on it. It works pretty well. Yeah.
Oh yeah. Maybe next time we try the irrigation pump.
There's a question from the audience about the use of IV glucagon.
We, as far as I remember, we never used. Yeah, we never used. Like I told you, we need to be very quick to finish the procedure. If you slow, probably you cannot accomplish the procedure.
The ideal location is just before the DJ, is it, flexure?
Yes, in terms of small bowel, yes. But in terms of the stomach, it will be on the greater curve.
Okay. Oh, sorry. Yes. Sorry. Yes. Okay. But the location is before the DJ flexure. You try and anastomose the stomach to it. Yes.
Yes.
Okay. Any other questions?
I think Srinivas, Dr. Srinivas is raising his hand.
Hi. Can you listen to me? I'm Dr. Srinivas.
Yeah, I can see you. Very handsome.
Thank you, sir.
You still working? It's Saturday, right?
Sir.
It's Saturday. You still working? Yeah, go ahead. Sorry.
Yeah, sorry. So we did a USGJ recently, a week or 10 days back. So I just like to share my experience, and I know from you also. So we used both buscopan and also glucagon to stabilize the small bowel. And we have injected around 500 to 600 of NS and saline. We could be able to deploy the hot axios easily. But the patient came back after 2 weeks time for a follow-up. So initially at the time of discharge, I was easily going into the jejunum from the stomach, through the hot axios. I went into the jejunum loop for 10-15 centimeters. I was confident that the stent was patent, everything is all right. I dilated up to 15 millimeter on a CRE. I discharged him. He came back after 2 weeks. So at that time, I found difficulty going into the jejunum, though I was able to go, but it was like a kink or something happened on the jejunal loop. So the patient was not willing for a repeat CT to know the flow of the contrast. So what do you think could have gone wrong, sir?
You mean you can pass your scope through lamps, but you couldn't go deeper into the small bowel. Is that correct?
It was like as if there was a kink on the small bowel. I was able to go through a pediatric scope, the small one, but the regular scope was not allowing into the jejunum the way it was allowed immediately after the placement of the stent. So was there some adhesion formation, or is it something has gone wrong there?
I think that the mechanism will be about the same when you try to do the double balloon, to try to do enteroscopy. That with the standard gastroscopy, probably it's hard to go through the small bowel. We have experienced one case that we have A-limb syndrome. So then we go through the lamps and we go back to the hepaticojejunostomy anastomosis, and that's easy because maybe the distance is pretty short. But because you go into the other way, you try to go down. So that might be the same problem with the standard small bowel enteroscopy. Maybe you can try the short version double balloon enteroscopy, I don't know, across the lamps.
I mean, if the patient is asymptomatic, I think you're fine. And the other option is just to inject contrast when you're in your endoscope and see the flow. I'm sure it's going to be fine.
We wanted to do a gastrograph and study oral CT, but the patient was somehow not willing after all these things.
So when you do your endoscopy under fluoro, just put some.
Oh, yeah. So we didn't have fluoro at that time. We were doing it in a diagnostic suit, so we didn't have that option of.
Yeah. So that would tell you.
Yes. Thank you.
Yeah, I think Chris. Yeah. Oh, please go ahead.
Oh, yeah, I was going to ask a question. That was a very impressive case, by the way. Congrats to Bharat and Purdue. My question is about the scope position. We know that we want the best position in the stomach is greater curve, as you mentioned. But a lot of times I found that the position that you can visualize the targeted small bowel loop is not right where the greater curve is located. So in that situation, what would you do? Would you just go ahead with that targeted small bowel loop, but the stomach side is not in the greater curve? Or would you try to find a different position and try to find a new loop of small bowel? Because I've seen on your video that the bleeding site is sort of like further away from the actual site of puncture that you finally succeeded, right? So I'm just guessing from looking at the video that you have tried multiple punctures at different sites. So some things must have happened in terms of, the proper site of puncture in that case. Yeah. So what's your comment on that?
Yeah, actually, if we couldn't find, so then we will try to move our echo endoscope into the other position. And in this case, at the beginning, actually, we got a very good position, but we cannot make the small bowel dilated enough. So then we have to go to unusual position that we can see dilated small bowel, and we try, but it's again, the small bowel wasn't been there for long enough for us to do a successful puncture. So then finally we went back to the the most comfortable position that we did in the past. And you're right, the position that we had the breathing actually is not a good position, but because we couldn't go to the desired position in the first time because of the leakage of the fluid back to the stomach, and we also have to start suctioning the fluid content from the stomach back into the system again to prevent aspiration of the patient. Because in this case we do with the conscious sedation without ET intubation, so we also have to be concerned about the aspiration of the patient as well.
Okay, so yeah, so you would emphasize that the position of the or the puncture site in the greater curve or along the greater curve is essential, and we should be sure that we get that position before we puncture.
Yeah. I don't know it's essential or not, but all the cases that I have done, I have a good outcome around that position. Maybe Chris can share your experience, because Chris also done a lot of GE cases. Yeah.
Right, because I've had some problems with different gastric positions. So I'm just wondering if if there is something very important in terms of the site of puncture location of the stomach. Yeah.
Chris, are you still here, Chris, or are you going to some beach or somewhere? Yeah.
I wish, no, but no, I'm not. No, I'm just looking at your videos and wishing that you didn't blur the background. No, but I think what has happened is that you, at least in our experience, we get a sense of where the small bowel loop is from a combination of the coronal axial CT, and the previous, usually most of our patients get an enteral stent first, and then it blocks, and then we end up doing the GJS for them. So you have a sense of where that loop is going to be already. And most often, the ideal position is reached when the stomach is dilated and the large, the greater curvature hangs down and gets you in that position. So it does turn out to be the greater curvature of the stomach. Whether that is associated with a better outcome or not, I can't really say. But we do look around for the most proximate loop and then target that. But what I wanted to add on also was to say that in all these cases, we always backload a guide into the lamps, into the axial system, so that once you get into the target, get your guide wire in there and put a couple of loops in case something goes wrong. You either slip out or you mal-deploy one of the flanges. You have that safety with the guide wire in the lumen, and then you can take a corrective measure and not have to worry that everything has separated and then you've got no options or you have to call a surgeon. I think this is something that certainly gives you an additional measure of safety when you're placing a LAMS under direct puncture.
I think that the techniques probably not standardized yet. So probably Dr. Nontali may have to write another review instead of complication. Maybe what is the best technique for gastroenterostomy?
Yeah, I'm like the expert. I'm an expert in the complications from the US guided gastrointestinal. Yeah, I think what Chris mentioned is important. Like the case that we have reported a perforation, we after the first deployment, we ended up removing the wire because we thought we were in, and after we removed the wire, we saw the peritoneum. Having said that, though, one thing I should mention is that when you do have a perforation, I think that the hole from the needle at the small bowel portion is very small, because in that case that I've reported, the pitfall, we only closed the gastric site. We didn't really close the small bowel site, and the patient did well. So I think the small bowel perforation sealed off very quickly. and we close the gastric perforation with just, a clip through the scope clips. So I think the perforation that occurs a lot of time can be rescued by just endoscopic clipping. And you can keep the patient NPO for a day or two, give them antibiotics, and see how they do. If you're really concerned, you can do a CT scan to see whether or not there's a leak or peritoneal fluid collection. Yeah.
Yeah, I guess it's more for the situation where your proximal flange is in the peritoneum. Then you really have a problem because you have a big hole connecting small bowel lumen and the peritoneum, and then you've lost your access from the stomach.
Right.
Yeah, that'll help you, to get out of that situation. Having the guide wire in place.
Right. Good point. Yeah.
Yeah, but we should get together, all of us, and write a complications updated complications thing.
Yeah, that's true. That's true.
Maybe.
Yeah.
Should we talk about a good technique first?
No,
but share the blame.
Well, next meeting will be in the orchard in Pradam Chai's place, where and we can discuss the complication rates.
Yeah.
I hope that next time we will have the face-to-face conference.
Yes.
So then I don't need to travel to the beach, to the garden by myself, try to make me comfortable, like a true conference in Sabah, right? Ryan, you also have a difficulty for it, right?
Yes. Well, listen, thank you very much. I think it was a very, very educational meeting for all of us. I think it was really great talks, great presentations, and I think this format has a role. In for all of us. Chris and Nontali and Pradam, I see you here. Do you think this is the way we can go forward? Maybe organizing this every few months or so.
I think so too. Yeah. Mm-hmm. I think it's very educational for us and for the fellows or even junior faculty to learn.
Right.
Yeah, this is a good platform.
Yeah.
I'd like to thank Pentax for helping us organize this, and Henry at GITAP to have got all of us together. Thank you very much. We will meet again. I think hopefully the next time we need to meet as the GITAP Society to organize the transition, which still hasn't occurred yet, but we must do it very soon.
Yeah, Ryan, you're president for life, man.
No. No. But thank you all. It's so great to see all of you. Chris, good to see you. Nontali, Pradam, Ben, Sandeep, Malay. Thank you all so much, and I hope everybody enjoyed the afternoon. Thank you very much.
Bye-bye.
Thank you.
Thank you, and bye, everyone. Thank you. Bye.
Bye.